Yeah.
Good evening, all of you. Respected President IADVL Kerala and all the dignitaries present here for panel discussion on dear friends. Each year, the World Leprosy Day reminds us the need to eradicate leprosy, a disease with a suffering and social stigma. For this, a collective effort is needed for early detection, treatment, and awareness creation. Today's program is a joint venture by Health Service, medical colleges, and our mighty organizations, Indian Medical Association and IADVL. IADVL President Dr. David Pudukadan took the initiative and put tremendous effort to plan such a panel discussion. I welcome you, Dr. David, to this meeting. I welcome our enthusiastic IADVL Secretary, Dr. Jovan, who coordinates the activity very well. Coming to Dr. Manikandan, Deputy Director of Public Health and State Leprosy Officer, is a sincere and dedicated officer in health service who adorned many important posts like District TB Officer Pathanamthitta, Deputy DMO Kollam, Medical Superintendent General Hospital Adur. I welcome you, Dr. Manikandan, for panel discussion. Then Dr. Roy R. Chandran, our efficient State Secretary of IMA. He is Professor of Physical Medicine, Government Medical College, Kozhikode. I welcome you, Dr. Roy. Dr. Pradeep S. Nair, Professor and HOD, TD Medical College, Alappuzha, is an eminent teacher, dedicated clinician with a special interest in leprology. I welcome you, sir. Dr. Sri Biju is a consultant dermatologist, Government Hospital of Dermatology, Kozhikode. He is an active leader of IADVL as well as IMA and an eminent organizer also. I welcome you, Dr. Sri Biju.
Thank you, madam.
Dr. Sarin, Associate Professor of Dermatology, Government Medical College, Thrissur, currently Vice President of IADVL Kerala, an efficient teacher with interest in clinical dermatology and leprology. I welcome Dr. Sarin. Dr. Ashwini, Assistant Professor of Dermatology, Government Medical College, Kottayam, an astute clinician and efficient organizer. I welcome you, Dr. Ashwini.
Thank you, ma'am.
Dr. Deepa Bailopalli, moderator for this session, is the enthusiastic convener of community dermatology, consultant dermatologist, Government General Hospital, Ernakulam, with a special interest in leprology. Previously held the post of District Leprosy Officer, Alappuzha. I welcome you, Dr. Deepa.
Thank you, ma'am, and good evening to everyone.
Now I welcome all the members of Executive Committee of IADVL and members of all the projects of IADVL. And welcome all of you in the audience, including doctors, nursing staff, and paramedical staff. And thank you. And over to Dr. David Pudukadan for the presidential address.
Good evening, respected faculty, dear colleagues and friends. Am I audible?
Yes.
Yeah. On behalf of IADVL Kerala, I warmly welcome you to this World Leprosy Day online CME. Leprosy is not a disease of the past. It is present in our OPDs today. Even now, we are getting a lot of cases in our OPD. Early recognition remains our greatest tool to prevent disability and stigma. This program is intended to bring together dermatologists, public health experts, and general practitioners to focus on what truly matters, spotting leprosy early in routine practice and initiating timely referral and treatment. The case-based panel discussion is designed to be practical, relevant, and directly applicable to daily clinical work. I thank our eminent speakers, panelists, IMA Kerala, especially the IMA State Secretary, Dr. Roy, NLEP Kerala, the SLO, Sir Dr. Manikandan, for their collaboration. I appreciate the Community Dermatology and Media Cell of IADVL for organizing this meaningful academic initiative. Let us reaffirm our responsibility as clinicians, spot the spots early, and stop the step to disability. Thank you and I wish the CME great success. Jai Hind, Jai IADVL. Thank you.
Now we have felicitation by the State Leprosy Officer, Manikandan sir. Manikandan sir, please.
Good evening. എല്ലാവർക്കും നമസ്കാരം. ഇതൊരു നല്ലൊരു പ്രോഗ്രാമാണ്. കാരണം എന്താ വെച്ചാൽ 2030 ലെപ്രസി ഇറാഡിക്കേഷൻ എന്നുള്ളൊരു സ്വപ്നമാണ് ലോകം ഇന്ന് ആഗ്രഹിക്കുന്നത്. തീർച്ചയായിട്ടും അത് അച്ചീവ് ചെയ്യാൻ കേരളം എന്തുകൊണ്ടും സന്നദ്ധമാണ്. അതിലേക്കുള്ള ഒരു യാത്രയാണ് നമ്മളെല്ലാം നടത്തുന്നത്. അതിൽ തീർച്ചയായിട്ടും ഡെർമറ്റോളജി അസോസിയേഷൻ മുൻകൈ എടുക്കുന്നത് വളരെ സന്തോഷമുണ്ട്. ഏതായാലും ഇതിൽ ഹെൽത്ത് സർവീസ് മുൻപന്തിൽ നിങ്ങളോടൊപ്പം തന്നെ ഉണ്ടാവും. നിങ്ങളുടെ സഹായവും കൂട്ടായ്മയും ഇതിലേക്ക് ഉണ്ടാകണം എന്ന് മാത്രമാണ് എനിക്ക് ഇപ്പോൾ പറയാനുള്ളത്. ഏതായാലും ഇന്നത്തെ CME നമുക്ക് എല്ലാവർക്കും ഒരു ഉപകാരപ്രദമാകട്ടെ എന്ന് ആശംസിക്കുന്നു. ഏതായാലും നമ്മുടെ CME തുടങ്ങട്ടെ. All the best.
Thank you, sir. We are privileged to have our IMA State Secretary, Dr. Roy R. Chandran, to felicitate us.
Respected President, Dr. David, Secretary, my sister, Dr. John Felicita, Treasurer, Dr. Bobby, Radhamani ma'am, Dr. Manikandan, Deepa, Sri Biju sir, Sarin, as to the other distinguished panelists and dear colleagues. So very good evening to all. As we observe the World Leprosy Day, I'm honored to address this gathering on behalf of Indian Medical Association Kerala State Branch, and proud to be invited as a panelist. And as you know, despite the remarkable progress, leprosy remains a public health concern that demands our continued vigilance. In India, India has got a dubious distinction of several things, like capital of diabetes, capital of hypertension, capital of cardiovascular disorders, and of course, capital of leprosy also, because the leprosy accounts for almost 50% of world's leprosy new cases, right, is in India. And Kerala, while we have achieved elimination status at state level, definitely there is pockets of endemicity, especially in the North Kerala, right? And then when I searched that, there is a troubling pattern recently that 8 to 10% of new cases detected in Kerala are children. That points to an ongoing transmission also. So the path forward lies in active case findings, not passive detection. And as I make Kerala, we can make a tangible difference through several initiatives like organizing regular CME programs to refresh the clinical acumen in early diagnosis. Especially we have got a wing called CGP, that is a wing for academic wing of general practitioners. We can conduct continuing CMEs in CGPs and conducting community outstretch camps. We can help in that in high burden areas, and definitely we can collaborate with NLP for intensified case detection drives. And most importantly, still there is a stigma. We can combat the stigma that drives patient away from the timely care. So let us renew our commitment today: zero transmission and zero disability. And as physiatrists, I can say we can try for zero disability and zero discrimination. So together we can make Kerala truly leprosy free. And Jai Hind, thank you very much.
Now moving on to the main part of the program, the panel discussion. Let me invite Dr. Deepa ma'am to start with the panel discussion. Ma'am, please.
Yes, ma'am, thank you. Thank you so much. Thank you, everyone. So let's go directly to the most important session here. our goal today to conduct this CME is just because World Leprosy Day this year's theme is to end disability, end the stigma associated with it, because leprosy is curable, but the challenge is the stigma. So the stigma is always knitted with disability. If you can prevent disability, leprosy is very much acceptable, because in the sense that, like diabetes, hypertension, there's not going to be any consequence. So here what happens is a painless patch is always missed to lead to very painful consequences, that is disability. So let us all join together, join hands to learn what is leprosy with full commitment and dedication. Let us detect the cases early. Let us treat early and prevent disability. So we will move on. My first question, I would invite our professor and HOD Dermatology, Government TD Medical College, Alappuzha, Pradeep sir. Can you please enlighten us about when should a general practitioner suspect leprosy? Is it really missed, or is it overlooked? Or what is the real scenario at present in your perspective?
Thank you, Deepa. Until otherwise, it is strongly suspect. Very often, the GPS got a chance of missing leprosy. So when should you suspect leprosy? When a patient comes with an asymptomatic hypopigmented or reddish color or coppery red macule or patch, which does not have itching or pain. That's the most important indication, because the word skin disease means there is itching. That is the general concept. But any patch which is asymptomatic should strongly be Hansen disease should strongly be suspected. Number two, when a patient comes with frequent burns on the hands, in the absence of diabetes or neurological disorder, again, it should be suspected. Or if a patient comes with a non-healing neuropathic plantar ulcer, in the absence of diabetes or neurological disease, it should be strongly suspect. So, in a nutshell, asymptomatic patch, no itching, no pain, is a marker of Hansen disease.
Thank you, sir. So we are going we'll go and we'll walk through case discussions which we usually see, which everybody sees in the OPD. But the only difference is maybe it is overlooked and missed or misdiagnosed, or we are treating the patient without a follow-up. The child or the patient goes window shopping to every other doctor, and the diagnosis gets missed. So this is a child case with a patch on the face. Is a 10-year-old male child. He's studying in school. He's presenting with a patch on the left side of face of 2 years duration. Duration is very important. All these 2 years, he has been to many doctors, having topical antifungal applications, but with no improvement at all. And there's a patch is there constantly. And they're also not much bothered because it is, as Sir mentioned, it is asymptomatic. No pain, no itching. It's a well-defined patch. Ashwini ma'am, can you please discuss this case for us? What will you do when this patient comes to you? What is your approach?
Thank you, ma'am. So from the picture, what you can see is there is a single well-defined, I would say looks like a raised lesion. And from the history, it's clear that it's persistent over a few years. And it's not responding to the usual antifungals that we usually give as a preliminary empirical therapy. So in this case, we should always suspect leprosy, because one thing, it's not having any symptoms. As Pradeep sir rightly told, the lesion is asymptomatic, it is persisting there for so many months and years, and it's not also waxing waning. A similar condition which can happen here is pityriasis alba, which is usually presents as a scaly plaque and later on a hyperpigmented macule. And another condition which can be similar in picture is tinea faciae, or the dermatophytosis of the face. So in dermatophytosis, the child will have pruritus or itching. So in this case, it is asymptomatic, so that is almost out. And pityriasis alba, or the hypopigmented macule that you usually find on the face of a child with waxing and waning, usually associated with dryness, that usually has a not a persistent course, but it has a waxing and waning course. So that's also almost out. So in this case, we have to suspect leprosy and you have to do a sensory testing. And the issue with sensory testing in such a scenario, one faces a lot of cross innervation by nerves. So we may not always find a sensory deficit here. Second, being a child may not be able to comprehend. So in such a scenario, we may have to go for investigations, or sometimes if the investigations are negative, we may have to keep the child under follow or even treat. But if suppose there is a sensory deficit identified, definitely it becomes a case of leprosy, because as WHO says, I hope all of you are familiar with the cardinal signs. So the first sign, cardinal sign of leprosy, is any lesion, hypopigmented or reddish patch with a definite sensory loss or impairment. So if the patient fits into that, the story is over there. It's directly leprosy. And if it is not, if there is no sensory loss, then either we may have to go for investigations, or we may have to follow up the child as the case may be. Ma'am, hope I was audible. Hello.
Yes, audible.
Ma'am, how do you test this patch? How do you go for a sensory test?
Sensory testing. So at a PHC level, we can do touch sensation testing by using a ballpoint pen. And hello. Yes, the common mistake that people do is either they use a wisp of cotton or feather or even pin. We have to use a ballpoint pen, and you have to do it perpendicular to the skin surface. And it should not be too, what you say, strong also. Gentle touch. And then first of all, you have to educate the patient what are you trying to do, and then first demonstrate it over a normal area with the eyes open, and then after once the patient gets it, you have to test it over the normal area, and then over the abnormal lesion that you're suspecting with the eyes closed. And an important thing is, don't stroke using the pen. And also don't ask leading question like, are you feeling? Ask them either to point using the index finger, or they can count 1, 2, 3 when they appreciate the touch.
Pradeep sir, is skin smear required in this case?
From the photo I have seen, this most likely to be a case of Hansen disease, borderline tuberculosis type. I think so. Whatever you're going to, the smear is never going to be positive. There is no point in doing a skin smear because it's going to be negative. We'll only expect the smear to be positive in the borderline lepromatous. There is no point in doing a skin smear. No point.
Thank you, sir. As per this single patch, when this patient came, I'm giving an imaginary scenario here. There's a child who came with a single patch. Usually in our busy OPD, what happens is we examine with the shirts out in the exposed areas, and we ask our health worker to just screen the case and leave the patient for screening and come back with, we also examine, but we need a lot of time. So what happens is, in such a case, initially with one single patch, we had made a diagnosis of HD-BT with paucibacillary type, and we have started a paucibacillary treatment. We tend to start a paucibacillary treatment. In fact, what happened was, next slide. this was the thing. The only area which we miss to examine is probably
Hello.
Dr. Deepa, you're not
No,
on.
Hello.
yeah. Deepa madam, I think, she lost the connection. She might have to wait a bit.
Tarun, can you please share it from your side?
Yeah,
so that
yes, I can. Yeah.
The question part. Yeah, can we go to the next question? The next slide.
No, there was a question just before that. No, what is
yeah,
the
there was a question
classification?
just before that.
Yeah. So
Yeah.
coming to the
this one.
classification, we
Yeah.
have a very simple classification for the treatment purpose also. We have basically two types, that is possibacillary, where the lesions are between 1 and 5 lesions, and the patient has to be smear negative with no thickening of nerves. So such cases we classified as possibacillary cases. And coming to the multibacillary cases, where the lesions can be more than 5 or more, and the patient can be smear positive and thickening of 1 or more nerves. And the second part of the question is coming to the treatment. Since last November 2025, we have a new guidelines for the treatment of Hansen's disease. Now, for all the cases, we are giving 3 drugs. Basically, we are giving Dapsone daily, monthly rifampicin, and monthly clofazimine along with daily clofazimine. In case of possibacillary, we give this for a period of 6 months. And for a multibacillary case, we give the same treatment for a extended period of 1 year. Earlier, it was only 2 drugs for possibacillary. Thank you.
Thank you, sir. Next slide. Mr. Tarun, can we go to the next slide?
This case was actually presented just to highlight the fact how important it is for us to examine thoroughly. So, Sri Viju sir has already given a good description. So the next.
So I'll stop my sharing so that ma'am you can share.
Yeah, Tarun. Yeah, I just it got off. I don't know why. So this has become a multibacillary case instead of a possibacillary. So the classification also changed, and this usually happens in our government service. If I'm not wrong, Manikandan sir, many times we will have to change the classification because most of the doctors are not dermatologists in the periphery, and we tend to find such instances. So this case, Hansen's disease, multibacillary child case, as Roy sir had pointed, what does it indicate? What's the significance? Ashni ma'am.
Actually, Roy sir had already given an introduction into this scenario, child case in leprosy. See, child case in leprosy is not just a number. It's actually an epidemiological signal, you can say. I would say there are more than one implication for child case in leprosy. One mainly because the incubation period of leprosy is very long, even up to 5 to 7 years. So that when we have a child case, it means that there is ongoing transmission in the community, and we have to actively screen all the close contacts of the child for any other active case of leprosy. One thing. Secondly, regarding stigma of leprosy, it is actually very, very challenging for a child, unlike an adult, because they have to deal with the peers, the school, and so many others. So that it creates more of mental stress and stigma to the child. And third, in case, unfortunately, if the child develops a deformity or disability, it amounts to amounts to decades of preventable morbidity and burden to the child. So as a whole, child leprosy has to be treated with a lot of caution, and it's an alarming sign for all of us.
Manikandan sir, can you please enlighten us on what IEC activities we should take up? It's not just enough for us to diagnose and treat the child alone. What else have we got to do?
നമ്മളിന്ന് സ്റ്റേറ്റില് പലതരം പല ടൈപ്പ് IEC ആക്ടിവിറ്റീസ് ആണ് നമ്മൾ ഉപയോഗിക്കുന്നത്. ഒന്ന് നമ്മൾ ഹൗസ് വിസിറ്റ് ആണ്. ഹൗസ് വിസിറ്റിൽ നമ്മൾ യൂഷ്വലി ഓരോ വീട്ടിലും കയറി ആ വീട്ടിലുള്ളവരെ നമ്മൾ എന്താ പറയാ, നമ്മുടെ കയ്യിൽ ഒരു പാംലെറ്റ് ഉണ്ടാവും. ആ പാംലെറ്റിൽ ഈ പിക്ചേഴ്സ് എല്ലാം ഉണ്ടാവും. ആ പിക്ചേഴ്സ് നമ്മൾ ഓരോ വീട്ടിലും കയറി ആ വീട്ടിലുള്ളവരെ നമ്മൾ ഈ പാംലെറ്റിൽ ആ പിക്ചേഴ്സ് കാണിച്ച് നമ്മൾ പോസിബാസിലറി അല്ലെങ്കിൽ മൾട്ടിബാസിലറി അല്ലെങ്കിൽ ഇത് ഹാൻസൻസ് ഡിസീസ് ആണ്, അതിന്റെ ഓരോ സയൻസ് ആൻഡ് സിംറ്റംസും നമ്മൾ എക്സ്പ്ലെയിൻ ചെയ്ത് കൊടുക്കാറുണ്ട്. രണ്ട്, നമ്മൾ നമ്മുടെ ഹോസ്പിറ്റൽസിൽ പോസ്റ്റേഴ്സ് നമ്മൾ എക്സിബിറ്റ് ചെയ്തിട്ടുണ്ട്. എസ്പെഷ്യലി OP ഏരിയകളിൽ നമ്മൾ പോസ്റ്റേഴ്സും അതുപോലുള്ള നോട്ടീസസും എല്ലാം നമ്മൾ എക്സിബിറ്റ് ചെയ്യുന്നുണ്ട്. കൂടുതൽ യൂസ് ചെയ്യുക. എന്നിട്ട് ആ പിക്ചേഴ്സിന്റെ ക്യാരക്ടേഴ്സും എവറിത്തിങ് സയൻസ് ആൻഡ് സിംറ്റംസും നമ്മൾ കൊടുക്കുന്നുണ്ട്. പിന്നെ മറ്റൊന്ന് എന്ന് പറയുമ്പോൾ, മൂന്നാമതെന്ന് പറയുമ്പോഴത്തേക്ക് സ്കൂൾ ലെവൽ ആക്ടിവിറ്റീസ് ആണ്. സ്കൂൾ ലെവൽ ആക്ടിവിറ്റീസിൽ നമുക്ക് സ്കൂൾ ഹെൽത്ത് പ്രോഗ്രാം എന്ന് പറയുന്ന പ്രോഗ്രാം തന്നെ ഉണ്ട്. ആ പ്രോഗ്രാമിൽ JPHN അല്ലെങ്കിൽ സ്കൂൾ ഹെൽത്ത് നഴ്സ് യൂഷ്വലി സ്കൂളുകളിൽ നമ്മൾ ടീച്ചേഴ്സിനെയും അതുപോലെ കുട്ടികളെയും നമ്മൾ ഈ സെയിം പാംലെറ്റ് അല്ലെങ്കിൽ നമ്മൾ ഈ പിക്ചേഴ്സ് നമ്മൾ കാണിച്ച് അവരെ എക്സ്പ്ലെയിൻ ചെയ്ത് കൊടുക്കുന്നുണ്ട്. അപ്പം ഇതാണ് നമ്മൾ മെയിനായിട്ട് നമ്മൾ യൂസ് ചെയ്യുന്നത്. കൂടാതെ നമ്മൾ ഇതിന് നമ്മൾ കുറച്ചുകൂടെ ആക്റ്റീവായിട്ട് നമ്മൾ ഈ ജാനുവരി 30 മുതൽ തുടങ്ങുന്ന സ്പർശ് പ്രോഗ്രാം ഏതാണ്ട് 2 വീക്സ് ആണ്. 30 തുടങ്ങി 2 വീക്സ് നമ്മൾ ഈ പ്രധാനമായിട്ടും അവയർനെസ് പ്രോഗ്രാമായിട്ട് തന്നെയാണ് യൂസ് ചെയ്യുക. ഈ ഇതിലാണ് നമ്മുടെ ആശമാര് ഞാൻ നേരത്തെ പറഞ്ഞതുപോലെ എല്ലാ വീടുകളിലും കയറി ഇറങ്ങി നമ്മൾ ഈ പ്രോഗ്രാം ചെയ്യുന്നുണ്ട്. ഇപ്പൊ മറ്റൊരു പ്രോഗ്രാമാണ് അശ്വമേധം എന്ന് പറഞ്ഞൊരു പ്രോഗ്രാം ഉണ്ട്. നമ്മൾ ആൾറെഡി നമ്മൾ കഴിഞ്ഞതാണ്. ജനുവരി 7 സ്റ്റാർട്ട് ചെയ്ത് നമ്മൾ 24 വരെ ഉണ്ടായിരുന്ന ഒരു പ്രോഗ്രാമാണ്. ആ പ്രോഗ്രാമിലും സെയിം, അത് കുറച്ചുകൂടെ മുന്നോട്ട് പോകും. അതായത് അവയർനെസ് പ്ലസ് സ്ക്രീനിങ് ആക്ടിവിറ്റിയാണ്. ഇപ്പോൾ ആ സ്ക്രീനിങ് ആക്ടിവിറ്റിയിൽ ഈ പ്രാവശ്യം നമുക്ക് ഏകദേശം നമ്മൾ 95 ഹൗസസ് ആണ് നമ്മൾ ഈ കഴിഞ്ഞ ജനുവരി 7 തൊട്ട് 24 വരെയുള്ള പ്രോഗ്രാമിൽ നമ്മൾ കംപ്ലീറ്റ് ചെയ്ത് ഏകദേശം 98.21% നമ്മൾ ആൾറെഡി കംപ്ലീറ്റ് ചെയ്തു. ഈ വിസിറ്റിൽ തന്നെ നമ്മുടെ ആശമാർ ഐഡന്റിഫൈ ചെയ്തത് അല്ലെങ്കിൽ സസ്പെക്ട് ചെയ്തത് ഏതാണ്ട് 43,000ഓളം സസ്പെക്ട് ചെയ്തു. അതിൽ നമുക്ക് ഏതാണ്ട് 26 കേസുകൾ ഈ 2 വീക്സിൽ നമുക്ക് ഡയഗ്നോസ് ചെയ്യാൻ കഴിഞ്ഞു എന്നുള്ളതാണ്. കൂടാതെ ബാക്കി കേസുകൾ സ്റ്റിൽ ഇപ്പോഴും ആ കേസുകൾ വരുന്നുണ്ട്. അപ്പൊ അങ്ങനെ നമ്മുടെ IEC ആക്ടിവിറ്റി എന്ന് പറയുമ്പോഴത്തേക്ക് അശ്വമേധം, സ്പർശ്, അതുകൂടാതെ നമ്മൾ അല്ലാതെ വീക്കിലി സ്കൂൾ ഹെൽത്ത് പ്രോഗ്രാം, അപ്പൊ ഇങ്ങനെ പ്രോഗ്രാംസ് ആണ് യൂഷ്വലി നമ്മൾ യൂസ് ചെയ്യുന്നത്. അപ്പൊ ഈ പ്രോഗ്രാമിലൂടെ തന്നെ നമുക്ക് കുറെ കേസുകൾ നമുക്ക് കിട്ടുന്നുണ്ടെന്നുള്ളതാണ് യാഥാർത്ഥ്യം.
Yes, sir. So, sir, in the perspective, as sir told, Hansen's is in the community actually. It is not in our OP alone. So we have to get down into the community at the grassroots level, and then we have to educate and get the cases. Voluntarily, the patients should come and report. For that, we need to conduct awareness programs widely. So that's the message sir has given. Very good, sir. Thank you, sir. So next we will be, I would like to ask Ashwini ma'am, how will you manage this case, ma'am, indeterminate leprosy?
Actually, this case will not be an indeterminate leprosy because the first lesion that on the face, that is a raised lesion. A raised lesion can never be indeterminate. So it is mostly HD, BT or TT, tuberculoid spectrum.
Ma'am,
And I
you're
expect
seeing the picture. There's another child.
on the buttocks. On the
There's not
buttocks.
the first child.
Again, again on the buttocks, the lesion again is unlikely to be
No, ma'am.
indeterminate.
There's a new screen. There's another
okay,
child.
new picture. Okay, fine.
Yeah.
So here you're seeing a hypopigmented and ill-defined macule on the face of a child, and this is actually very tricky because we get to see such lesions mostly in our OPD, and we are confused whether to what to label it. So the most closer differential diagnosis here, one is pityriasis alba, about which I already discussed. It's usually a hypopigmented macule which starts scaly, but usually the scaling is not seen by the parent, and they come with hypopigmented flat lesions. And they give a typical history of waxing and waning, and mostly they will have dryness and other atopic symptoms associated. So that is not leprosy, that is likely to be pityriasis alba. The second thing that you should see is tinea versicolor. The common term that we Malayalis use is chonanga or temal. So that will have a well-defined border and some polycyclic border, some few lesions adjacent to it, like satellite lesions. All these are in favor of tinea versicolor, or what you call temal or chonanga. And coming to indeterminate leprosy, that will be a hypopigmented macule that will remain as such persistently there for months. So the problem with indeterminate leprosy is the sensory sensation may be normal. As such, in indeterminate, it may be normal. Being a child may be difficult to comprehend. Third part, being the face, again, cross innovation plays a role, so that sensory loss may not be appreciated. So sensation we cannot depend on in this case. Second, we can take a smear. Again, it can be negative. Biopsy also may not yield a positive finding most of the time. So in such a scenario, most of the time, if histopathology yields a result, we can go for treatment. Otherwise, we may have to keep the child under follow-up. And if the lesion is persistent, we can even do a rebiopsy or even empirically start on therapy. But that is very tricky because diagnosing a case of leprosy empirically is not at all easy. So diagnosing as well as treating indeterminate leprosy is a very tricky thing in our practice. And one good thing is that 70% of the indeterminate may resolve on its own. Only 30% may enter into one of the spectrums that we usually tell as Ridley-Joplin classification. I hope that's clear.
Yeah, can indeterminate leprosy, a patch like this, go in to develop lepromatous leprosy?
Sure. If that 30% that I told, it can go into one of the defined spectrums. As when we call it indeterminate, that means it has not entered into one of the spectrums that we tell as Ridley-Joplin classification. So it can either resolve by its own or it can enter into one of the spectrums. In that case, it becomes a real case of leprosy, so that we can classify based on the posibacillary or multibacillary and treat. Being indeterminate, it is difficult to classify as well as treat.
Yeah, so indeterminate leprosy doesn't mean it is a benign leprosy. It can go in for lepromatous also. So thank you, ma'am, for enlightening us on that. So next I would like to invite our Pradeep sir to teach us this case. Such cases we should not miss at all. So this is a case story, 50-year-old male. He had multiple raised skin lesions over the face, ears, trunk, and limbs since 2 months duration. And history, he is giving a history of numbness over a lesional site, ichthyotic patch, with loss of sensation for 2 years. So how will you approach this case, sir? This is the patch which was there. This is a plug which was there right from the...
Yes, right. First of all, can you take that to photos of the earlobe infiltration? Photos. Can you just go to the first photo, madam? The clinical photo. Can you hear me, madam? Okay.
Yes.
No problem. See, this patient now, when such a patient comes, what's important thing which is there is earlobe infiltration, multiple papules, plaques, and nodules, and of course, hypopigment skin lesion. So, the history-wise, we have to ask the patient whether the patient, what is the residence of the, is it an area which is endemic of Hansen disease? Any other patients got similar lesions? Then we come to the skin lesions. Now, this patient has got lesions suggestive of both lepromatous and tubercle type. But he has got earlobe infiltration, multiple papules, plaques, nodules, which are generalized but not symmetrical. At the same time, he has got a hypopigmented anesthetic ichthyotic patch on the left thigh. That is also there. But at this point of time, for the general practitioners and non-dermatologists, I'll say, I will make a diagnosis of lepromatous leprosy. But going a little bit more scientifically, because the patient has got lesions suggestive of tuberculoid type, like the ichthyotic patch, ideally, this could be a case of lepromatous leprosy subpolar type. You may ask why it cannot be BL. It can be BL also because I don't have the smear status in this patient. And in addition, the patient also has got another lesion if I remove the photo. So this patient probably downgraded from a tuberculoid spectrum to the lepromatous spectrum. No harm in saying this lepromatous leprosy, scientific lepromatous leprosy, subpolar type is what I diagnose. You can see the papules, plaques. There is generalization, but symmetry is not there. You can see the symmetry is not there. Yes, madam. Next slide can go. Slide can be changed.
Dr.
So one
Deepa?
second, sir. So
Okay.
just 1 second, sir.
Okay, no problem. Yeah, this is the ichthyotic. This type of lesion you won't get in lepromatous leprosy. You only get in a tuberculoid spectrum. So probably he has been not diagnosed by many people. It has been missed, and he has downgraded from a tuberculoid to probably a mid-borderline to a lepromatous. That is what has happened to this particular patient.
Yes, sir. So what will be the smear when it's
The smear
tested?
should be positive if it is lepromatous leprosy, at least a bacteria index of 6 plus an MIF at least more than 25%. It should be positive. You can
Yes,
see
sir.
the
What
earlobe
is this?
infiltration, which is usually a feature of lepromatous leprosy.
Okay, sir.
The cardinal signs, I think Ashwini has mentioned. I think there's only a repetition.
So
But
any
here,
mimickers?
cardinal signs of leprosy, Hansen disease actually are, an hypopigmented or reddish area of hypersensitic area of skin, thickened and or tender nerves that repeat with sensory motor deficit. Very important. Thickened nerves alone is not a cardinal sign. Along the course of the nerve, you should have sensory motor deficit. Then only becomes a cardinal criterion. Of course, the third is smear demonstration. Any one is required to make diagnosis of Hansen's disease. And here, because there is a definite cardinal criteria, there is a hypopigment ichthyotic acidic patch. I will not consider here differential diagnosis. There's no need because there's already one cardinal criteria. But if that hypopigmented acidic ichthyotic patch was not there, only papules and plaques, then I'll entertain a strong suspicion of leprosy, but still then other details can be considered. Here, there is a definite cardinal criteria, no need of any differentials.
Yes, sir. So Ashwini ma'am, how will you confirm the diagnosis? Then there's no need for confirmation, as sir told, but still for the other doctors to understand, how do we confirm?
Exactly. Actually, in this case, it is a very clear-cut case because the ichthyotic patch plaque will mostly have an anesthesia. So it will fulfill the first criteria, that is a skin lesion with sensory loss. And thickening, there may be thickening that is not mentioned in the question. Third criteria, smear, mostly it will be positive. So to differentiate from BL and LL, we take smear from an earlobe as well as the normal from the lesion. And in this case, both if you take from the papules, you may get a smear positive. Earlobe also may be positive. Ichthyotic patch, there may be a doubt because if it is in the tuberculoid spectrum, as Sir has said, it is downgraded, there may be a confusion, but still. Anyway, smear will be positive from any one of these lesions. And if it has gone to LL, even the normal skin will be positive. So that's the way you can differentiate between VL and LL. So in this case, invariably smear will be positive from one of these sites. That is the first investigation that we can do, easier investigation. Second, we can go for a skin biopsy. So in skin biopsy, again, there you will definitely get a granuloma. And being towards the lepromatous end, you may even get foamy macrophages and a macrophage granuloma, even Gren zone will be visible, and AFP staining will also be positive in the biopsy specimen. So these are the investigations you can do, but I would like to add one more thing. You need not wait for the investigation results in this case to start treatment, because as per the WHO cardinal signs, one sign is enough to start the treatment. You just need to classify it into PB and MB or MB. So in this case, as there are more than 6 or more lesions, definitely it goes into MB, and smear will also be positive. So it will be an MB multibacillary case of leprosy, and you can start treatment as soon as you clinically diagnose it. And you can always take a biopsy or smear, and which can support your diagnosis.
Yeah, thank you, ma'am. So what are the other types of leprosy, ma'am? We have already covered tuberculoid, indeterminate, and borderline lepromatous MBT. What are the other types?
See, to the non-dermatologists here, I would say you need to look into only 2 types of leprosy. One is paucibacillary, one is multibacillary. So that is the WHO classification for the treatment purpose. So the 3 things that we look into, one is the skin lesion, second is the peripheral nerve thickening, third is the smear. That is the slit skin smear that we take, not the biopsy. Presence of AFB in the slit skin smear. So coming to the skin lesion, if there are 6 or more skin lesions, you count the skin lesions. If there are 6 or more, it is multibacillary. If there is any sort of nerve involvement, as per the new WHO criteria, any sort of nerve involvement, it becomes multibacillary. And third, if there is smear positivity, again it becomes multibacillary. And it should be stressed that any of these 3, if positive, it becomes a multibacillary case. That means to become paucibacillary, the skin lesion should be less than or equal to 5, no nerve involvement, and no smear positivity. Okay, that is and. Whereas regarding multibacillary, the 3 criteria are or. Any of the 3, if there is presence, you have to classify it as multibacillary. So summary is don't undertreat the patient anyway. So if you are in doubt whether it is 6 or 5 skin lesions, put it as multibacillary. Hope it's clear. And that is the classification for the treatment purpose. For a more academic purpose, we have the Ridley-Joplin kind of classification where you have tuberculoid at one end and the lepromatous at the other end. So actually, it's not easy to discuss this in a short period of time, but I'll try. See, suppose the main most important characteristic feature of leprosy is that everything depends on the host immunity. The specific cell-mediated immunity of the host. It is not the general immunity that gets suppressed with HIV or the steroid intake. It is the specific cell-mediated immunity that is different among different individuals. So if the CMI is very high, the body will try to combat the bacilli and will try to restrict everything to one single point and will get a very good granulomatous response and a raised lesion. And that is what is called a tuberculoid leprosy. And the local inflammatory response or the granulomatous response will destroy all the nerves there, small nerve twigs there, as well as the bacilli there, so that if you take a smear, the smear will be negative there. And also the sensory testing will be having an absence of sensation. So that is a single lesion. Also, there will be loss of hair because of the infiltration, as well as the autonomic nerve fibers which are destroyed will lead to loss of sweating. So that it will be a dry or ichthyotic, anhydrous, well-defined raised lesion which has loss of sensation. And on smear, it will be smear negative. That is what is a tuberculoid leprosy. And usually there may not be any peripheral nerve thickening along with that, because the CMI, very high CMI, has already been successful in containing it to one single point. Now imagine another patient who has a little less immunity compared to this. This I'm talking not about the generalized immunity. Again, I'm stressing. So a diabetic patient will not have a higher chance, or HIV patient will not have a higher chance. It is the specific CMI to M. leprae. So another patient who has a little less immunity, the body will try to confine to one single point, but it will not be successful. So the lesion will not be that well defined. It will be partly defined and a little spillover, which will look like satellite lesions. So that is BT. And smear may be positive, may not be. And now we'll discuss the other end.
Can you see this
Lepromatous
picture,
leprosy.
ma'am?
Yes.
Can you see this picture? This is what you meant, satellite lesion.
Yes. Here you can see that the lesion is not that well defined. It is partly defined on one side, and the other side it's well defined. And you can see the spillover, which are called the satellite lesion. So whenever you see satellite lesion, it is a case of BT. And sensory testing will be having, you will have loss of sensation here. Smear may not be positive. And now I'll discuss the other end, because there is no time. We'll discuss the other end, that is lepromatous leprosy, where the...
Madam, can you just highlight on this finding also? Here, this boy
Actually,
has
I'm
got a
not able
patch on
to,
the
it's not
forearm.
clear. Picture is not clear.
He's got a little bit of less hair on the patch.
Okay,
It is just,
okay.
these are some clues which the general practitioners need
to know.
to
Yes,
how to
exactly.
differentiate from other manicures.
Yeah. And towards the lepromatous end, what happens? The CMI is very, very low or even absent, so that the body is not able to, or the CMI is not able to contain the bacilli to one single point or to one nerve. So that there will be bilaterally symmetrical multiple lesions throughout the body, and peripheral nerves thickening throughout the body. And also, wherever you take smear, it will be positive, because the bacilli is there throughout. And the sensory loss may not be confined to the skin lesion, but it will be patchy, which is called glow and stalking anesthesia. And one important point I would like to stress is the skin lesions in lepromatous leprosy may not have sensory loss, because
that is
the
very
granuloma...
important takeaway point.
Yeah, because leprosy can present with lesions which are not having sensory loss, because the granulomatous response is not that good as in tuberculoid that we already discussed, so that the cutaneous nerves may not be that destroyed. So what happens is, in tuberculoid there may be a pressure also which of the granuloma, because of which the nerve sensory loss occurs, but in lepromatous it does not occur, and the granuloma will be a little more ill defined, so that the lesions may not have sensory loss. However, if you take a smear will be positive. And where do you find the sensory loss in lepromatous leprosy? It will be in the hands and feet, which is called the glove and stalking anesthesia. And you may have blisters or burns, which the patient did not notice, even trophic ulcers. So that is the presentation. And another important finding is the earlobe infiltration and the eyebrow infiltration, leading to loss of lateral eyebrows, which is called madrosis. And all this happens because of the bacilli infiltrating throughout the body. And you also have that leonine facies, about which we are all familiar with in the old movies and all. So that is called, that is the earlobe infiltration. This is the leonine facies. You can see there is no eyebrows for the patient on the left. The lateral eyebrow is lost, and also infiltration of the face as well as earlobes. So the other one is facies leprosa, where you have the sunken nasal bridge as well as loosening of the teeth because of the loss of alveolar processes. So that, and also you can see the distal digits which are lost, and the ulnar nerve palsy. So these are all the old pictures of leprosy which are not seen nowadays. We luckily have an early diagnosis and treatment before the patient goes into such disabilities. So that is Ridley-Joplin classification. First one was WHO for MBPB, next Ridley-Joplin. Just I would like to tell about a few rare types of leprosy. One is pure neurotic, which is usually missed, because pure neurotic presents with the second cardinal signs that we were discussing. That is the peripheral nerve thickening with loss of sensation or muscle weakness of the area supplied by that nerve. For example, an ulnar nerve which is thickened along with the ulnar claw hand, or the loss of sensation in the ulnar area. So such patients will not have any skin lesion. Pure neurotic leprosy will not have any skin lesion. So such patient is unlikely to consult a dermatologist. And unfortunate to say, it is usually misdiagnosed and finally comes to dermatologist very, very late. So that is pure neurotic. Then there are many other rare types like histoid leprosy, luteal leprosy. I think it's not easy to describe all those things and convince you all in this online platform. So that's all.
So, Pradeep sir, can you just go through these findings just once for everyone to know, sir? These pictures, just to highlight, images speak more than words.
Okay, so, right. Actually, the picture showing the hypopigmented multiple macular lesions could be either a borderline tuberculate to mid borderline. And the middle picture is showing well-defined papilla shiny from appendage normals. Most likely it would be histoid leprosy, middle. Most likely. And of course, the last photo with the earlobes definitely is LN, lepromatous leprosy. So we have got from a BB to histoid to lepromatous leprosy.
What about this picture, sir?
Here you can see the patient has, there is a superseded medrosis is there, and there's infiltration mainly of the forehead also, and there is eye involved also, and there is also collapse of the bridge of the nose. So most like this also should be a case of lepromatous leprosy.
Yes, sir. Thank you very much, sir. So next we will go to the question part. Sarin sir, can you tell us something about the chance of infectivity in this patient? Sarin sir, are you here?
Thank you.
Yes, sir.
Oh.
Yes,
I'm
sir.
audible.
Yes, sir. You're audible.
Yeah, first of all, thank you for this opportunity. And I also take this opportunity to congratulate Pradeep sir. He's one of the best teachers for his national number. Okay, so the chance of infectivity in this patient, it is high because it's a multibacillary patient. So AFB count in such patients is expected to be 10 raised to 11. It's billions
Sir, could
of
you be a
bacilli.
little louder, sir? Could you be a little louder, closer to the mic?
Okay. Am I audible now?
Yeah. Quite better.
So this is the chance of infectivity in this patient is quite high because it is an MB patient, multibacillary patient, and the AFB count in such patients is usually 10 raised to 11. That is 1 inch of tissue can harbor billions of bacilli. It is not millions, can crores in our. So if the patient is not on treatment and the contacts are in close association with the patient, the chance for getting infection is high. But as mentioned earlier, depends on the specific CME of the host. And the same bacilli causes tuberculoid spectrum and lepromatous spectrum. So also multibacillary cases have mucosal involvement with probable nasal discharge, increasing the risk for transmission. And it is said that contact for at least 20 hours per week for a period of 3 months or more is usually required. So short contact may not cause a problem, and it is mostly spread through respiratory route. So there is no need to be scared. And for those who are forced to have long contact, such as the family members of a multibacillary patient, if they satisfy this criteria, that is at least 20 hours per week of contact for a period of 3 months or so, we can now give this single dose rifampicin prophylaxis also. And it has to be noted that it's not transmissible like diseases we commonly encounter, like this corona, measles, and chicken.
So what is the route of transmission, sir? Actually, these points have to be addressed in detail, because even sometimes even doctors don't handle cases of HD. As soon as they have the slightest suspicion, there's a tendency to refer rather than to approach in a way to diagnose and treat. Maybe there are fears of how it spreads, and whether it spreads by touch, close contact, one-time contact.
No, it is not likely to spread by such short contacts. The disease mainly spreads by respiratory droplets, and nasal mucosa is main portal of entry. And in multibacillary cases, we may have risk of transmission, but this not to be scared. That is the point, because prolonged contact is required, and we have some immunity because we exposed to the bacilli anyway. And there is no evidence that through intact skin it spreads. And other types of transmission are very rare, and only prolonged contact produces. So the short contact like what we have in hospitals while dealing with the patients, such things are not likely to spread the disease. And what we try to do is to have a clinical diagnosis. And in all possible multibacillary cases, we start the treatment also. So that itself will reduce the risk of transmission by more than 99%.
Yes, sir.
And
that's great.
After COVID, most of us are wearing face masks also. And the route of spread is mainly respiratory. That also will help if you are so scared. So it is not by itself a scary.
So thank you very much, sir. That was a good, enlightening concept. Pradeep, sir, I had a patient who was around 30, and he was having Hansen's disease, lepromatous leprosy. And his marriage was fixed. His wedding was fixed. He asked me whether I could get married and have children immediately, or should I use any contraceptive measures. Is there any chance of infertility for me with the disease per se and with my drugs? So what would you say, sir, if in such cases?
Absolutely no problem. This patient get married and have children. But you have mentioned is a case of lepromatous leprosy. Lepromatous leprosy, mycovite and lepra, can involve the seminiferous tubes, and this lead to testicular atrophy, and the patient can have infertility. That is why you get testicular atrophy and gynecomastia in lepromatous leprosy. But you can definitely get married, but there is a chance of infertility. Especially if it is a long-term lepromatous leprosy, not types. Yes, it can develop infertility. And even initially, it can affect the seminiferous tubules, and later M. lepra, if not, it can affect the interstitial cells of leading even to impotence.
I had a case while doing my PG, sir, under Professor Pavitran, sir. The boy had leprosy since he was 7-year-old. He developed lepromatous leprosy, testicular atrophy, and he became a pseudo Klinefelter. Very tall, unicoid. So there is infertility. Just wanted to mention how important it is for all of us to diagnose early, so that even infertility also can be prevented in these cases. So can this patient's wife get pregnant while he is on treatment? That was his
Absolutely
question.
no problem. The wife can get pregnant. And I'll take that question 6. No, there is no contraindication of the first line drugs in pregnancy. I mean, Damson, clofazim, rifaximin. All these 3 drugs can be given during pregnancy, but none of the second-line alternative drugs can be given during pregnancy. Ofloxacin, minocycline, and clarithromycin cannot be given during pregnancy. All the first-line drugs can be given.
So in case of hepatitis, drug-induced hepatic dysfunctions, what would
That
you
becomes a problem if it's a pregnant person and develops hepatitis. Then we cannot go for the alternate regime. So it is actually a bit of a problem management. It depends upon whether the patient is mere positive or not. But if the patient has got hepatitis, the 2 most drugs which we are taking into the context is Damson and rifaximin. Both can cause but more Damson. So what we do, we can continue with clofazimine, repeat the hepatic enzyme levels, and once the hepatic enzymes become normal, we can restart rifaximin. Because we give only monthly rifaximin. And after that, if the hepatic enzymes are normal, you can continue with clofazimine and rifaximin.
Well taken, sir. Manikandan sir, can we, when these patients come into the private sector, can we give them MDT free of cost as it's done in our government sector?
Okay. നമുക്കറിയാം ലെപ്രസി എന്ന് പറയുമ്പോഴേക്ക് ഒരു നോട്ടിഫയബിൾ ഡിസീസാണ്. ഇപ്പം TB പോലെ തന്നെ ലെപ്രസിയും ഒരു നോട്ടിഫയബിൾ ഡിസീസാണ്. വൺസ് നമ്മൾ ഡയഗ്നോസിസ് ചെയ്ത് കഴിഞ്ഞാൽ ആ പേഷ്യന്റിനെ നമ്മൾ നോട്ടിഫൈ ചെയ്യുകയും അത് രജിസ്റ്റർ ചെയ്യുകയും വേണം. യൂഷ്വലി അങ്ങനെ നമ്മൾ പേഷ്യന്റിനെ നോട്ടിഫൈ ചെയ്യുകയും രജിസ്റ്റർ ചെയ്യുകയും ചെയ്തു കഴിഞ്ഞാൽ ആ പ്രൈവറ്റ് ഹോസ്പിറ്റൽ ആകട്ടെ ഗവൺമെന്റ് സെക്ടർ ആകട്ടെ ആ പേഷ്യന് ഫ്രീ ഓഫ് കോസ്റ്റ് നമ്മൾ അൺഇൻറ്ററപ്റ്റഡ് ഇതിൽ നമ്മൾ ഡ്രഗ്സ് നമ്മൾ പേഷ്യന്റിന് സെർവ് ചെയ്യുന്നതാണ്. പിന്നെ അതുപോലെ തന്നെ ഈ MCR ചപ്പൽ അതുപോലെ RCS സർവീസസും നമ്മൾ ആ പേഷ്യന്റിന് ഗവൺമെന്റ് സെക്ടറിൽ നമ്മൾ ഫ്രീ ഓഫ് കോസ്റ്റ് എല്ലാ സർവീസും നമ്മൾ ഇപ്പൊ കൊടുക്കുന്നുണ്ട്, കൊടുക്കാനും പറ്റും. ഓൺലി ഇതേ ഉള്ളൂ, നമ്മൾ പലപ്പോഴും ഈ പേഷ്യന്റിന് രജിസ്റ്റർ ചെയ്തില്ലെങ്കിൽ, നോട്ടിഫൈ ചെയ്തില്ല എന്നുണ്ടെങ്കിൽ അത്തരം പേഷ്യന്റിന് നമുക്ക് എന്താ പറയാ ഫ്രീ ഓഫ് കോസ്റ്റില് മെഡിസിൻ നമുക്ക് സപ്ലൈ ചെയ്യാൻ പറ്റാതെ വരും. അതുകൊണ്ട് തന്നെ ഞാൻ ഒന്നുകൂടെ പറയുകയാണ്, ഇപ്പൊ പലപ്പോഴും നമ്മൾ ഇപ്പോഴും തന്നെ അറൌണ്ട് ദിസ് ഇയർ 2025 ജനുവരി ടു ഡിസംബർ 535 കേസാണ് രജിസ്റ്റർ ചെയ്തിട്ടുള്ളത്. ഇത് വെച്ചാൽ ഗവൺമെന്റ് സെക്ടറിൽ നിന്നും DHS ലെവലില്, ദെൻ മെഡിക്കൽ കോളേജ്, ഗവൺമെന്റ് മെഡിക്കൽ കോളേജ് ആൻഡ് കുറേയൊക്കെ പ്രൈവറ്റ് ഹോസ്പിറ്റലിൽ നമ്മളോടൊപ്പം നിൽക്കുന്നുണ്ട്. അവർ രജിസ്റ്റർ ചെയ്ത കേസുകൾ മാത്രമാണ്. അത് കൂടാതെ കുറെ ഹോസ്പിറ്റൽസ്, ഇപ്പൊ മെഡിക്കൽ ഈവൻ ചില പ്രൈവറ്റ് മെഡിക്കൽ കോളേജസ്, ദെൻ ഹൈഫൈ പ്രൈവറ്റ് ഹോസ്പിറ്റൽസ് നമുക്ക് ഈ ഇത്തരം ഹാൻസൺ ഡിസീസ് പലപ്പോഴും രജിസ്റ്റർ ചെയ്യാതെ വരുന്നുണ്ട്. അത്തരം പേഷ്യൻസിന് നമുക്ക് പലപ്പോഴും മെഡിസിൻ ഫ്രീ ഓഫ് കോസ്റ്റ് സപ്ലൈ ചെയ്യാൻ പറ്റാതെ വരുന്നുണ്ട്. അപ്പൊ അതുകൊണ്ട് ഒന്നേ ഉള്ളൂ എനിക്ക് എല്ലാവരോടും പറയാനുള്ളത്, ഇത് നോട്ടിഫൈഡ് ഡിസീസ് ആണ്, അത് നമ്മൾ രജിസ്റ്റർ ചെയ്യണം. രജിസ്റ്റർ ചെയ്താൽ നമുക്ക് ആ പേഷ്യന്റിന് ഫ്രീ ഓഫ് കോസ്റ്റ് നമുക്ക് മെഡിസിൻ നമുക്ക് കൊടുക്കാൻ പറ്റും. അടുത്തൊരു ക്വസ്റ്റ്യൻ വെച്ചാൽ കോൺഫിഡൻഷ്യാലിറ്റി. തീർച്ചയായിട്ടും ഇതിനകത്തൊരു ലെപ്രസിയെ സംബന്ധിച്ച് TB പോലെയല്ല. TB ആകുമ്പോൾ നമ്മൾ കുറെ കൂടെ വിശാലമാണ്. സ്റ്റാഫുകൾ ആ വീടുകളിൽ പോവുകയും അതിന് വേണ്ടുന്ന മറ്റു നെയ്ബേഴ്സിനെ എല്ലാം നോക്കാറുണ്ട്. ബട്ട് ഹിയർ പേഷ്യന്റ് ബുദ്ധിമുട്ട് വരാത്ത രീതിയിൽ ആ കോൺഫിഡൻഷ്യാലിറ്റി നമ്മൾ മെയിൻറ്റെയിൻ ചെയ്യാറ്. ഒരിക്കലും നമ്മൾ ആ വീടുകളിൽ സ്റ്റാഫ് പോയി ശല്യം ചെയ്യുകയോ അല്ലെങ്കിൽ നെയ്ബേഴ്സിന്റെ വീടുകളിൽ കയറി ഇറങ്ങിയോ ചെയ്യുന്നില്ല. ബട്ട് നമ്മൾ ആ വീട്ടില് ആ പേഷ്യന്റ് കോൺഫിഡൻഷ്യാലിറ്റി ബ്രേക്ക് ചെയ്യാതെ തന്നെ ആ വീട്ടിൽ ആ പേഷ്യന്റിനെ ട്രീറ്റ് ചെയ്യുന്നതോടൊപ്പം ആ വീട്ടിലുള്ളവർക്ക് നമ്മൾ പ്രൊഫൈലാക്സിസ് റിഫാമ്പിസിൻ നമ്മൾ കൊടുക്കുകയും ചെയ്യുന്നുണ്ട്. ഇപ്പം ഒന്നുകൂടി ഞാൻ ഉറപ്പിച്ച് പറയുകയാണ്, കോൺഫിഡൻഷ്യാലിറ്റി ഈ ഹാൻസൺ ഡിസീസിനെ സംബന്ധിച്ച്, പ്രത്യേകിച്ച് ലെപ്രസിയെ സംബന്ധിച്ച് നമ്മൾ ഒരു കാരണവശാലും ആ പേഷ്യന്റ് അനുവാദമില്ലാതെ ഒരിക്കലും നമ്മൾ ബ്രേക്ക് ചെയ്യുന്നില്ല എന്നുള്ളതാണ്.
So well taken, sir. പിന്നെ MCR ചപ്പൽസ് അല്ലേ സർ, അവർക്കും കൊടുക്കാൻ പറ്റുമോ?
കൊടുക്കാം. എല്ലാ പേഷ്യൻസിനും നമുക്ക് കൊടുക്കാൻ പറ്റും. എല്ലാ പേഷ്യൻസിനും നമുക്ക് കൊടുക്കാൻ പറ്റും ഗവൺമെന്റ് സെക്ടർ.
നോൺ ഗവൺമെന്റ് സെക്ടറിലും കൊടുക്കാൻ പറ്റുമോ സർ?
നമുക്ക് ആ പേഷ്യന്റ് രജിസ്റ്റർ ചെയ്യണം. നോട്ടിഫയബിൾ ഡിസീസ് ആയതുകൊണ്ട് ആ പേഷ്യന്റിനെ രജിസ്റ്റർ ചെയ്യണം എന്ന് മാത്രമേ ഉള്ളൂ. അവിടെ ഒന്നുകൂടെ പറയാണ്, ആ പേഷ്യന്റിന് ഒരു കാരണവശാലും അതിന്റെ കോൺഫിഡൻഷ്യാലിറ്റി ബ്രേക്ക് നമ്മൾ ചെയ്യത്തില്ല, ബ്രേക്ക് ചെയ്യില്ല.
Yes, sir. Yes, sir. Well taken, sir. So, Biju, sir, when we get such cases in the government sector, we are all in the government sector. So, presently, is it, sir has already mentioned, is it mandatory to report?
Yeah,
Or
sir
can
has
you
already
skip,
told about it.
even
It
if
is,
it's
it is
not,
a notifiable
Yeah,
disease
he's
since
already
last
told.
year. So we are supposed to
Yeah.
report to our district authorities. That is the district leprosy officer has to be reported, and they will inform the medical officer from where the patient has come, and they will send the health inspectors and all the other public health staff to just for the screening of the family members and other social contacts. So that is very important, as sir has already told about it.
Yeah. Manivan sir, Nikusht portal ഇപ്പൊ നമ്മൾ യൂസ് ചെയ്യുന്നുണ്ടല്ലോ സർ, ആർക്കൊക്കെയാണ്, who all can access this? Is it open to everybody?
നികുഷ് പോർട്ടൽ നമുക്ക് എല്ലാ മെഡിക്കൽ ഓഫീസറും അത് ആക്സസ് ചെയ്യാവുന്നതാണ്. ഇടയ്ക്ക് വെച്ച് ചെറിയൊരു പ്രോബ്ലംസ് ഉണ്ടായിരുന്നു, അതിപ്പം സെർവർ ഇഷ്യൂസ് ഉണ്ടാകും, അതൊക്കെ കറക്റ്റ് ചെയ്തു. എഗെയിൻ ഇപ്പൊ വീണ്ടും നികുഷ് പോർട്ടൽ നമുക്ക് അവൈലബിൾ ആണ്. ഇപ്പോൾ ഇതിനകത്ത് ഒന്നുകൂടി സെൽഫ് സർവീസ് ഉറപ്പ് തരികയാണ്. ഏതെങ്കിലും തരത്തിൽ അവർക്ക് എന്തെങ്കിലും ട്രെയിനിങ്ങോ ഈ നികുഷ് പോർട്ടലിനെ കുറിച്ച് എന്തെങ്കിലും ട്രെയിനിങ്ങോ എന്തെങ്കിലും വേണം എന്നുണ്ടെങ്കിൽ നമുക്ക് നമ്മൾ ഫ്രീ ആയിട്ട് തന്നെ ആ ടീമിനും, ഏതെങ്കിലും ഹോസ്പിറ്റൽ ആവട്ടെ, ഏതെങ്കിലും ഡോക്ടർ ആവട്ടെ, അല്ലെങ്കിൽ ഡോക്ടർ ഗ്രൂപ്പ് ആവട്ടെ, അവർക്ക് നമ്മൾ ഇത് ഫ്രീ ആയിട്ട് നമ്മൾ ട്രെയിനിങ് കൊടുക്കുകയും ചെയ്യുന്നുണ്ട്. ആക്സസ് നമ്മൾ അവൈലബിൾ ആക്കുകയും ചെയ്യുന്നുണ്ട്.
Sir, and then, can you brief us on Nikusht portal, what it is and how it's running?
ശരിക്കും അത് നികുഷ് ശരിക്കും നമുക്ക് ഈ ഇതുപോലുള്ള ചെറിയൊരു നമുക്ക് ഈ മീറ്റിംഗിൽ നമുക്ക് കംപ്ലീറ്റ് ചെയ്യാൻ പറ്റില്ല. അപ്പൊ എനിക്ക് തോന്നുന്നു നമുക്കത് മറ്റൊരു ദിവസം നമുക്ക് ശരിക്കും നമുക്ക് ചെയ്യാവുന്ന. ഓക്കെ.
Yeah, thank you, sir. It's fine. So we are coming to Sarin sir. Can you give your comments on these cases? Because when a doctor sees such cases, does it go as leprosy? Can it be overdiagnosed? And what are the differentiating features? Are they mimickers? And how do you differentiate? Sarin sir? Sir, so Viju, you want to take up this question?
Hello?
Yeah, Sarin sir. In these pictures, are they mimickers of Hansen's, and how will you differentiate? Like, how do you differentiate from Hansen's?
Yeah, as we already said, we had to check for cardinal features, but nowadays there are so many atypical presentations of Hansen's, which make it increasingly difficult. So we had to suspect.
So can you see the screen, sir? The screen is shared.
Dr. Sarin, വോയിസ് ഭയങ്കരമായിട്ട് ബ്രേക്ക് ചെയ്യുന്നുണ്ട്. അതാണ് ഓഡിബിൾ അല്ലാണ്ടല്ല, ഇടയ്ക്ക് ബ്രേക്ക് ആവുന്നു.
Can you hear me
Sir,
better now?
Screen pictures, can you diagnose and differentiate from HD? It's for the general practitioners. Some tips, can you give some tips to them how to differentiate this from Hansen's?
I can see two pictures.
Yeah. On psoriasis and tinea vesica. What are the salient features? How to differentiate, sir?
Yeah, psoriasis the main feature, clinical feature we use is the demonstration of post-pitch sign. That is, if you remove the, it will be scaly plaque, which you remove, will reveal point bleeding spot. Okay, but there can be mimics. And since we had a case which was initially diagnosed as psoriasis and treated with methotrexate, which is the cheapest medication available for extensive psoriasis. But later, the same patient came with a hypopigmented patch, and that showed sensory impairment. That led to further evaluation, and finally turned out to be a case of Hansen's. So there can be mimics, but usually there is, you cannot be faulted if you miss a case like this. But what you have to know is there can be atypical presentations also in case of Hansen's disease. Not, it is said that diseases don't read textbooks. So any case can present in any form. You have to even while you are learning about the typical presentations, you have to know about the likelihood of newer presentations which can happen. So we had cases like presenting like sweet syndrome, psoriasis, pure neurotic, which was missed for 8 years, which went to neurologist and all. So many one.
These are also extensive hypopigmented.
It seems like tinea versicolor only.
Yes, yes. So what is the catchy, what's the points of, what's the tip you can give for the general practitioners to say it is not HD?
Okay, we only have the cardinal features. The things we usually miss may be the sensory impairment. We tested thoroughly, especially the differentiation between heat and cold temperature sensitivity. So the first sensation to be lost in leprosy can be cold sensation, then heat sensation, then fine test, then only pain. So if you test only the pain sensation using a needle, you may miss. And also, certain cases there is dissociated sensory loss. That is only the temperature, and read the second case with and there is no logic making a rare diagnosis. So the order should be first you have to think of the common diagnosis, then rare presentation of common, then rare diagnosis, then only rare presentation of rare. So this can be maybe a rare presentation of rare diagnosis. So you don't have to think about it first. You have to think in that order only, but you have to keep in mind it can finally turn out to be a case of Hansen's. Less likely, but still possible. So you have to keep under follow all cases, and you have to also know that hypopigmentation in tinea versicolor can persist for months. That also is possible. And sensation can be tricky. So keeping under follow.
Can I add a word? Deepa, can I add a word regarding
yes,
for GP's sake? See, sometimes we may have a type of lepromatous leprosy known as hypopigmented macular type, where you get generalized hypopigmented macules. The same condition we encounter the GPs is extensive pityriasis versicolor. You can do a simple test. In pityriasis versicolor, there will be scale. There's a test known as scratch test. You just scratch with the nails, you get scale. That is not seen in the Hansen disease space. For GPs, it's a simple test. You get scaling in pityriasis versicolor. It is usually not seen in Hansen. But an Hansen disease with a type 1 reaction and subsiding will present with scaling, mimicking psoriasis.
Yes, sir.
Ma'am, can I add a point?
Thank you,
Thank
sir.
you, sir. That's well taken. Yeah, Ashwini ma'am.
Pardon.
So summarizing whatever Sarin sir and Pradeep sir said, just a simple tip to general practitioners. Whenever there is itching, it is unlikely to be leprosy. And whenever there is scaling also, it is unlikely except in a subsiding type 1 reaction. So scaling and itching are two signs or symptoms and signs which makes the leprosy diagnosis less likely. But we cannot always take it as a whole, because sometimes what the patient tells may not be, again, when we ask, is there really itching, they may tell no itching. So that has to be taken care of. So, but as a rule, we can take, like, if there is itching and scaling, it is likely to be leprosy. But having all the atypical features nowadays, we have to always have the high degree of suspicion of leprosy in any skin lesion you see, and try to match it with the cardinal signs of WHO that we have mentioned. That is any skin lesion with sensory loss. So if there is sensory loss, convincing sensory loss, it has to be leprosy only.
Yeah, thank you, ma'am, for the point. So there's another case wherein this was a female patient, aged 62. She had pain and edema of her dorsum of right hand. And she was treated with a lot of anti-inflammatory NSAIDs. She was diagnosed, in fact, as de Quervain's disease. And it was like that for some 6 months. She gradually progressed to develop some sort of weakness of the hand. That was where the doctor referred the patient very intelligently to us to rule out Hansen's disease. And detailed history showed that she had occasionally numbness of the right hand and difficulty in holding the spoons while cooking and getting out of the stove and putting it up, all that. So after this was a history she came with. So an examination, there was a, this was a find. These were the findings. You can see. Sarin sir, can you discuss this case?
Yes, there is a type of
How would you
leprosy.
approach and what are the findings also, sir?
Okay, in the picture, you can see on the side of the thumb, it is the thickened nerve, which is the radial cutaneous nerve, found to be thickened in this case. And there is a, as you described, there is a sensory impairment, also weakness, and weakness of the right hand. So, but there is no skin lesion as such. This also can be a presentation of leprosy. And as we have mentioned, no skin lesion is called pure neurotic leprosy. Leprosy can be primarily a disease of nerves, then only the skin. And here, there is no skin lesion as such. And here there is pain and edema of right hand with numbness and weakness. So the probable nerves involved can be radial cutaneous and also ulnar, as you described the weakness also. Ulnar also is like.
Yes, sir. Thank you for that, sir. And is there a disability, Sribiju sir, in this patient?
Yes, she has a disability and she falls under the grade 2 disability classification.
So what is grade 1, grade 0?
Grade 0 means there is no anesthesia or no visible deformity. Grade 1 is where you have the lesions are anesthetic but no visible deformity, and grade 2 is the one that we have seen already, where you have a visible deformity or damage, which can even include the loss of corneal sensation and all other eye changes, which are visible. As
So the
the
anesthesia,
speakers have already told about all these things. That is,
Yeah.
medrosis comes under that, saddle nose comes under that, trophic ulcer comes under that. It's already been told by the speakers, early speakers.
And it's not actually a patchy hypoesthesia, am I right, sir? It is a palms and soles. The hypoesthesia or anesthesia is confined to the palms and soles and labeling the disability. So thank you very much, Sir Biju, sir. And now coming to our Roy, sir. Sir, usually in this case, you just saw this case. Is it usually mistaken for several other diseases? Are there any mimickers, close mimickers, which you have come across?
Yes, ma'am. That's classical mimicker is syringomyelia, cervical syringomyelia, where the crossing fibers of the spinothalamic tract will be involved, so the pain and temperature will be lost. Second will be diabetic mononeuritis or any other peripheral nerve injury like traumatic or ulnar nerve palsy. So these are the common things in upper limb, ma'am, or a radiculopathy, a cervical radiculopathy. So where so to differentiate, I think we should differentiate between these things, right? So in Hansen's disease, definitely there can be a hypopigment, but in this case it is not there. And nerve thickening. So that is actually here there is a nerve thickening, right? So this was not mentioned previously. Like we can also help you in PMR department can also help you in diagnosing cases with we have got in most of the PMR departments we have got ultrasonography. So the high resolution ultrasound can be used for assessing the nerves and we can assess the nerve thickening also. So that may help you in diagnosis because when you palpate it, that is a subjective thickening, but an objective thickening can be made by doing an ultrasound, especially in asymmetrical enlargement. Like in this patient, one side the nerve is thickened like an ulnar nerve. In elbow, it is usually we used to say take the CSA, the cross-sectional area. Usually it is 8 to 10 mm in Indians, mm square in Indians. So if it is more than 10 or 12, that means the nerve is definitely thickened, especially if it is asymmetrical. So we can also help you in differentiating with USC also.
Thank you, sir. Many times we do fall into a fix, whether the nerve is thickened or not, whether it is pure neurotic or something else. So this ultrasound will help. So
yes,
thank you for that.
definitely.
Yes, sir.
We can. You should use it. I think we should use that.
Yeah, we must use it. Exactly.
Yeah.
So is it available in all the centers, tertiary centers?
Most of the PMR departments and in radio diagnosis, if they are experts in assessing the peripheral nerves, they can definitely do that. And that can also be used in other things like I can detect early disease in a pure neurotic variety. And you can it also help you in guiding nerve biopsy. You can specifically take the biopsy from that inflamed site. You can detect lepra reactions with Doppler with increased blood flow, so that you can start steroids early. You can even assess the monitoring of treatment response by assessing the gradual decreasing the CSA. So the cross-sectional area, yeah. So it can be used in many.
So that's great, sir. It's non-invasive also.
Yeah. Non-invasive, simple. That is actually that is USC is now considered as an extension to your clinical diagnosis or clinical equipment.
Dr. Deepak, can I add a few
I think
things?
all of you get trained in assessing nerves with USC. USC is available very cheap, non-invasive, very simple. Simple can also get trained within 1 or 2 weeks with training.
That's great, sir. Yes, Biju sir, you wanted to ask something?
I work in a leprosy hospital. We have around 40 to 50 cases, and most of them require the MCR chapels, and we refer our patients to the PMR department in Calicut Medical College, and they provide us footwear free of cost. And if we have any case doubtful whether the nerve is thickened or not, what we do is we refer to the PMR department of Calicut Medical College. I don't think any other department in Kerala are doing this in the PMR department. I think only Calicut is doing. That's what I feel. What is
Roy
your
sir
opinion, Dr. Roy?
won't
No, sir,
admit.
it can be done
No.
it is there in Trivandrum, in Alappuzha, it's there in Thrissur.
Thrissur,
Then
I
in
think the
Pariyaram,
radiology department is doing it.
In Palakkad, I've got a friend, Soni. He also is abreast of it.
Yeah, dermatology resident have had done a thesis on this a couple of years back.
So even
Calicut.
Doppler can be done, right, sir?
Yes, ma'am. Can assess lepra reaction.
That's a good information, sir.
It's a good investigation, actually.
Yeah. So can we move on? So, Ashwini ma'am, could you just tell us what is the beak test positive? How to elicit? It's a simple test.
Okay. See, basically, we have to assess the nerve function for sensory part as well as motor part. So in a busy OPD, we not be able to do all the tests that we study during our MBBS or MD. So the simple test for the voluntary muscle testing, simple voluntary muscle testing is what is in hands is what is called a beak test. For that, it's by doing a beak test, we actually test all the three nerves, that is ulnar nerve, median nerve, as well as the radial nerve together. If madam is having a picture, if you are having a picture, it will be easy. Basically, we know the ulnar nerve is involved in the extension of the interphalangeal joints and the flexion of the metacarpophalangeal joint. So when you make a beak like this, that action is being tested. And we know median nerve is the nerve for opposition, and wrist extension is with the radial nerve. So when you do the beak test with the like a beak of a bird with the wrist extension, you're testing all the nerves together. Suppose the patient is not able to do that, that means there is one of the nerves having paralysis or weakness. So that is a easy test that can be done. And the second, for the lower limb, there are similar tests. One is you can ask to walk the patient on heel. That is a test for common peroneal nerve. And for the posterior tibial nerve, you can ask to spread the toes or to stand on toes. So these are the important voluntary muscle testing, easy testing, quick muscle testing that you can do in your busy OPD.
In fact, every patient and the follow-up must undergo all these tests to rule out whether
has to be done. This has to be done at the start of treatment, as well as you have to do it during follow-up. And I would like to add this point to the disability grading. See, grade 1 is anesthesia. Grade 2 is any visible deformity. It can be anything which is visible, from trophic ulcer to whatever deformity we are seeing, which is visible. So our aim is not to have the patient not to make the patient progress from 0 to 1 to 2. So whatever the patient is right now, we have to either keep it as such, or we should not allow it to progress to another grade of disability. That is the most important thing. So we have to keep doing these tests, including sensory. I didn't mention about sensory already mentioned. So including both, we have to continue doing during our follow-up visits, even after treatment completion, actually.
That's a very important
Can I add one thing? There's another simple test. You just assess the grip of the patient. Good grip is by the combination of the radial nerve and the long finger flexus, which is mainly supplied by the median nerve. So if there is a good grip, we are left with two other nerves, only the distal median nerve and the ulnar nerve. So if you can assess the APB, the abductor pollicis brevis, and then 6, then the hand examination is finished. It's a very simple test. Just assess the grip. The grip is okay, then we can do an APB and the abductors, the finger abductors. Then examination is over. So that will take around 10 seconds.
That's a good info, sir. Thank you for that answer, sir. So I think should we go for the questions to Roy, sir? Because sir might leave after some time. So can you take up your questions, sir?
Okay, ma'am. Not after some time, just now. The train is at 10:30, ma'am.
So in a claw hand, in patients with claw hand, foot drop, what are the DPMR measures? What is DPMR and what are the DPMR measures you will advise for the patients?
Sort of you are aware, DPMR is disability prevention and the medical rehab. So in a case, an acute claw hand, so that the treatment should start very early. So the thing is that the most important thing is the patient education. So where this patient education should be there, they should do it lifelong, like test the hot objects with the elbow, not with the hand. That is probably the most simple and the most important thing. And use gloves while cooking. Avoid tight tools. And like we advise the patients with diabetic neuropathy, like inspect their foot daily. So these patients should inspect their hand daily. So and keep the nails short and do not cut the callus with blades. They're simple things, right? And skin care, daily skin care should be there. You know that soap, scrape, and oil routine is there. That everybody is it's known to all. And in anesthetic hand, they can use padded gloves and cloth handle covers for the household utensils, and avoid carrying heavy bags with fingers. That may also produce a pressure injury. Within minutes, that can produce a pressure injury. And the next thing is regarding the splints. Before that, in acute neurotic phase. So the thing is, we should prevent the claw deformity and avoid undue stretching of the inflamed nerves and the muscles. So in acute phase, we used to give resting intrinsic plus splint. So in claw hand, there is an intrinsic minus deformity. So we will be giving an intrinsic plus splint where we'll keep the MCP, the MCP joint in flexion of 70 degree, the IP in full extension, and wrist in slight flexion. And this should be on full time initially for initial few weeks. And regarding the exercise, only as mentioned, only gentle range of motion exercise. Don't do strengthening exercise. And if there is edema, there should be proper elevation. And in chronic phase, that usually happens after 3 to 6 months, there is no recovery. That is considered as a chronic phase. Here we start using function splints in clawing. This case is having clawing, right? So there is an anti-claw splint or Namasivaya splint is there. And we can also use, there is an opposition, there is no opposition, we can use an opponent splint. And if there is a weak wrist, along with this, we can also give a cock-up splint. And the thing is that we should restore the grasp and somehow we should make the activities of daily living independent. And in this phase, we can start strengthening of the remaining muscles. So uninvolved muscles should be strengthened because in these patients, they may need tendon transfers like in FDS transfer, etc. for lost lumbricals. So that is a simple thing. The surgery for there is surgical rehabilitation also, like this FDS, that is known as FDS four-tail transfer for this claw hand. That is a simple surgery. We will be taking the FDS, the flexor ditorum superficialis tendon of the ring finger, that will be separated into four tails and will be attached to the lumbricals. That is a simple thing. Because I was to leave, that is why I made it in a hurry. My train is by 10:30. So can I make a leave, ma'am?
Yeah, sir, you've done a great job. You've added a lot of info to us, which we didn't know. Many fields you've enlightened us.
There was
Thank
a question.
you so
There
much,
was a
sir.
question on a foot drop also, but unfortunately, I may not be able to cover that portion, ma'am. I'm
It's
very
okay,
sorry.
sir. It's okay. We will get back to you again, sir, in the next
Okay, thank
CME.
you. Thank
So
you,
thank you
ma'am.
very much. So these are some pictures of type 1 reaction. So what exactly is type 1 reaction, Sri Biju sir?
Hello.
Sri Biju sir,
Yeah,
what
yeah,
is
yeah.
that?
I'm here. See, it's a type of acute hypersensitivity reaction to the bacterial antigens. It's a type 4 hypersensitivity reaction. Yeah. Yeah, it can be seen, usually it is seen in borderline cases of leprosy, and it can occur when we start the treatment. It can also occur in a few percentage of cases before the treatment is started, and in few cases, very few negligible cases, it can be also observed after stopping the treatment.
Yes, sir. And Sarin sir, is there any particular risk, any category of patients who will develop type 1 reaction? Can you predict in certain cases? Sarin sir?
Hello?
Pradeep sir, can you take this question?
Yes.
Yes,
Hello?
Sarin sir is here.
Yes.
Yeah.
Yeah, particular category of patients who are at increased risk of type 1 reaction. So usually seen during MDT and subsequent 6 months following it, and mostly in MB cases, and extensive disease, borderline cases, and those having WHO disability grades 1 and 2 and diagnosis, and having a facial patch, and pregnancy also is a risk factor, and having bactericidal drug regimens, and even vaccinations, enlarged ulnar nerve diagnosis. These are and also self-reporting cases. So this is actually a boon in case of Hansen's. Why? Because Hansen's disease bacilli do not produce any exotoxin or endotoxin. So even if they carry large burden of the disease, there is no toxin or no symptom to the patient. So if the patient comes with a sudden onset of reddish new lesions or sudden nerve palsy, the patient will report to a healthcare worker. So that is the helpful thing about development of reactions.
Pradeep sir, many times patients hearing that it is type 1 reaction, when we write it on the OP sheet and we talk to the patient, this is type 1 reaction. Immediately they tend to presume that, oh, this is a reaction to the medicines. And
Yes.
very silently they stop the medication and go for other modalities. So how do you handle such cases, sir?
Actually, in the more my clinical situation, I find it is a type 2 lepra reaction where the patient, because it presents with generalized lesion either. That is where the patient strongly suspects it's a drug reaction. They will stop it. In type 1 reaction, they have the feel the disease is worsening. So what I do, and I tell my postcards also, before starting MB, MDT or PP, MDT, I tell the patient during the course of treatment, sometimes the lesions may become larger, new lesions will occur, you may get nerve pain. Do not stop the treatment, you come to us to take care of. Same in case of type 2 reaction also. I find that it's more in type 2 anal reaction where the patient feel it is a drug reaction, and they are more likely to stop the drugs in a type 2 reaction rather than a type 1.
Yes, sir, that's a very good point you have shared with us. So how do you differentiate it from ENL, Ashni ma'am? Type 1 reaction and type 2 reaction.
To make it simple, I would say I would like to tell how it occurs. So basically type 1 reaction, as Sri Biju sir said, it's a type 4 hypersensitivity. So when I mentioned Ridley-Jopley classification, I said TT having high CMI, LL having very low CMI. So there is a spectrum in between, that is VT, VB and BL. So whenever there is a fluctuation in immunity in the CMI, there will be a shift between these. So that is what is called a type 1 reaction. So whenever there is such a shift, the already existing lesions has an inflammation. So the already existing skin lesion becomes inflammatory. There will be erythema, edema, pain over the existing skin lesion. Some of the lesions which the patient did notice earlier may be presenting that time only. So that is exaggerated inflammation of the existing skin lesion. Same thing can happen to the nerve. The existing thickened nerve can become inflamed. It can present as neuritis. It can be either nerve pain, it can be nerve tenderness, it can even go to the level of sudden nerve palsy or even a nerve abscess. So this is how type 1 reaction presents, and there is no constitutional features, there are no constitutional features associated with this. Okay, so it's just an inflammation confined to the whatever was existing. Coming to the type 2 lepra reaction, it is actually a type 3 hypersensitivity. I think going back to the microbiology, immunology, we know type 3 is an immune complex mediated hypersensitivity. So in order to have a good immune complex, we should have high bacillary load. So this happens in the bacilliferous cases like the BL, LL, etc. So this immune complex can get deposited throughout the body, anywhere in the body. So what happens? There will be inflammation throughout the body. There will be constitutional features. Plus skin lesion will be erythema nodosum leprosum or ENL, which are actually nodules which which will last for 2 to 3 days. Then they actually appear in crops towards the evening hours, and then they scale and go off in 2 to 3 days, which is associated with constitutional features. And since the immune complex can get deposited anywhere in the body, maybe only a few organ systems like CNS and your ovary, female reproductive system is not involved, all other, or even lung, almost all other systems in the body can get involved, and you can add itis to all other systems, and that is the clinical feature of type 2 reaction, that is orchitis, uveitis, arthritis, dactylitis, hepatitis, glomerulonephritis. You can just spare the ovary, CNS, and what did I say? I forgot. Okay, fine. So that is it. Basically, it is a systemic reaction. Type 2 lepra reaction is a systemic reaction which occurs in bacilliferous cases, whereas type 1 reaction is a reaction which occurs confined or the exaggerated inflammation of the existing pathology, that is the lesion or the nerve, and not associated with constitutional features, which usually occurs in borderline cases.
So we'll move on to the next case. Pradeep sir, can you discuss this case? 32-year-old man, he had lepromatous leprosy. He had a diabetes, also type 2 diabetes. He was started an MDT. He responded to prednisolone. He had ENL also. So with 40 milligram, he responded, but each time we brought down the dose, he got a flare. So this has been there for 8 months, and we're not able to wane off steroids. Diabetes is shooting up. ENL is not going off. Liver is also damaged. It's a complicated case, sir. So can you discuss this, especially for the dermatologists in the group?
Okay. So definitely by definition, this becomes a chronic ENL. ENL more than 24 weeks becomes actually chronic ENL. And this patient is confounded because he has got diabetes also. Now, in such a patient, the best drug would be actually thalidomide. But starting thalidomide alone is not going to help this patient. For thalidomide to have its effect, initially we require a small dose of steroid. So what they say, 40 milligram should be the starting dose of pedicine, along with 100 milligram TDS thalidomide. You will have to control the diabetes, nothing. We have to add insulin or something. Then you taper this a little bit rapidly. You can even taper the thalidomide to 100 milligram BD and OD. I find combination of steroid plus thalidomide gives the best effect in chronic ENL, even recurrent ENL. But in spite of that, if you are finding that not much control, certain alternative drugs have been mentioned. I don't have much experience. Alternative drugs, I say apremilast can be used nowadays. They say minocycline can be used. And of course, the DNF alpha inhibitors, not possible in this extremely poor patients. That I would say my first line of treatment, the combination of steroid Plus, here we can add definitely thalidomide can be added with no problem. But another thing to be kept in mind nowadays, chronic ENL and recurrent ENL now can be a manifestation of drug resistance. So they advocate a chronic ENL patient, if possible, to send for a drug resistance studies. Okay. Now coming to the second, after 6 months of MDT patient that SGFT, STPT is raised. Now 52 and 60, I will tell you, actually we have formed algorithm for LFT abdominis in HT when I was in Rwanda along with the medical gastroenterology, but we are well past time, so I have the algorithm with me, it will take some time. Now, the rule is we don't have to worry about SGOT 52, SCP 60. According to medical gastroenterology, 3 times more than normal is considered to be definitely increase in hepatic enzyme. You take 5-day course of azithromycin, if hepatic enzymes don't elevate, something wrong with your liver, no doubt about it. This 52 or 60, there is no problem. But suppose say it is 90 or 100, then what you do? 2 of the 3 drugs we are giving, Damson and Rifampicin are the potentially hepatotoxic. Of this, I would put Damson as number 1. As I said, before you stop both, you can continue with clofazimine. No problem. After 2 weeks later, you repeat the hepatic enzymes. See, it may be a transient increase. 52 and 60 was most likely a transient increase. It comes to normal. You continue clofazimine, start monthly rifampicin, not Damson. You start. Continue. 2 weeks later, again repeat the enzymes. If the enzymes are normal, you can continue with clofazimine and with the monthly rifampicin. But suppose if it's a highly bacilliferaous case, say histoid or LL, you can add 400 milligram ofloxacin, no problem. But the protocol dictum is do not restart Damson if there is initially a very gross increase hepatic enzyme levels. So, but after 2 weeks of repeating for 5, even after starting rifampicin, also the enzymes are not coming down, then you go for the alternate. Simple. That is what.
That was very clear, sir. Thank you so much, sir. So I think we are coming to the fag end of the CME. What are the associated systemic complications? Already Ashwini ma'am has addressed all those. And how do you manage complicated case of HT with type 2 reaction and dysfunctions? Pradeep sir has just now told. So we're skipping all those questions. Just to show that the images speak more, these are all manifestations of Hansen's disease. So Riju sir, can you just enlighten the audience on what are the features?
Yes. Yeah, you can see ulcers over the pressure points, plantar aspect, and over the inner aspect of leg. It could be trophic ulcers, as you have already mentioned.
Yes, sir. These are all trophic ulcers in different forms. Should we rule out malignancy in a chronic trophic ulcer?
Yes. If we see any growth along the margins of the ulcers, we come across such cases in our patients because we have a lot of such cases, long-standing trophic ulcer cases, and sometimes we send the patient to the surgery department and take a deep biopsy, because deep biopsy from our side is not that easy because we don't have a sterile conditions to take a surgical biopsy. So many times we get malignant changes in such cases, and that part is surgically removed, including the underlying bone. So that is, and so in a fresh case, what we do is we prescribe MCR chapels for these patients. Government gives it free of cost, and our patients also get it free of cost. And the cobbler comes from the PMR department, and they mark the pressure points, and they have over the pressure points, they just give a gap in the inner sole of the footwear.
Yes, sir. Thank you,
That's
sir. And what is single dose rifampicin? When is it given to the contacts?
Yeah, it is
Sir, sir has
it's a,
already highlighted.
yeah. It's a type of post-exposure prophylaxis that's given for in the case of Hansen's disease. And before giving it, the medical officer is informed. The team goes to the index case house. Before that, they have to get a consent from the person, the index case, and after that, they make a list of because it's very important, because we can get a case from the close contact, that is patients, the persons who are staying close to the patient. 10 times there is more chance of getting it from such people. And the neighborhood is also being screened, and also the social contacts are screened. And in case what happens is, we give a dose of 600 milligram rifampicin. Single dose is given. That is given to any person above 2 years of age. Adults also it is given. And if there is any history of any liver or renal problems, we don't give it. And usually the protective value of this is around 25%, and some references say it can go up to 50%. And the dose is also different for different age groups. If it is above 15 years of age, we give 600 milligram, and 10 to 14 years we give around 450 milligram, and 6 to 9 years we give around 300 milligram, and it is given as a single dose, and it gives the protection for at least 2 years. Yeah.
Yes, thank you, sir. And some patients on diagnosis, they ask us a question like, should I go and stay separately like in COVID? Should I stop mingling with my wife and children? So what would you advise, sir? This is actually a rationale of giving rifampicin is already
it's
there.
because rifampicin, after taking a single dose, kills around 99% of the bacilli. So after a single, there is nothing health concern staying with this person.
Yes, sir. Thank you, sir.
Madam, can I add a point?
Yeah, sure, ma'am.
When such a question we encounter, on a positive note, we can always say that a single dose will kill all the bacilli, and in a public health point of view, the patient is no longer infectious. But we'll have to keep one thing in mind: the family members were staying with the index case, the person previously also. So there can be other cases in the family already, or he can already have infected other members in the family, and they may be in the incubation period. And since the incubation period is very long, we should always give them a precaution that you have to always be vigilant about any skin lesion developing in the body. And at that point itself, you have to actually screen all the contacts. And after screening, you have to give in a positive note, you can give a message like the incubation period is long, so that you should be vigilant about any skin lesion that happens in your body, especially in children. And you have to seek healthcare if you find something. That point can be added in a very subtle manner without making them afraid.
Okay.
Yeah,
Can I add one more point?
Yeah, definitely.
As per the new guidelines, it is said that we have to screen the patient for at least 5 years. The family members, they have to screen twice a year. They have to screen for 5 years, and retrospectively also, if you're seeing a case who has completed all the treatment, we have to screen retrospectively all the contacts he had for the last 5 years. That's been added now.
So I think we will skip with all these. These are all theory part, and can you just put it in a nutshell, sir? Like dapsone, what you must take care of, for rifampicin, what you must take care of, and clofazimine, in very brief.
Yeah, you have to be aware of the common and potentially serious side effects. Both are important. And potentially serious, maybe it should be attended to first. And it need not appear early. It can be late also. It can happen in 1 to 4 weeks. With the dapsone, it can be agranulocytosis and drop in hemoglobin due to hydroxylation end products. And you have mentioned peripheral neuropathy and dapsone syndrome, which is the most dreaded complication, as well as hepatitis. All can happen. So, one thing we can do is ask about maybe G6PD we can do in certain selected cases. And practically what we can do is the indication to stop dapsone will be a hemoglobin drop in by 2 gram and symptomatic anemia, severe hemolysis, etc. And dapsone syndrome, or it is a type of drug hypersensitivity syndrome, can happen usually within 3 months. It need not be immediate, and there can be systemic complication, including 20% mortality. And liver may be the most common organ. And rifampicin can be shock syndromes, the discoloration of the body fluids, which are considered normal with rifampicin. And hepatitis also is a complication, but rifampicin is given only once a month in leprosy. What we have to remember is both leprosy and tuberculosis can coexist, and in such cases, if we give the leprosy regimen, we will produce a resistant tuberculosis. So that also has to be ruled out. And about clofazimine, commonest complications can be the side effects can be ichthyosis and darkening or reddish brown discoloration of the skin, which will subside 6 months after stopping the treatment. That you have to explain to the patient while starting the treatment. That is important.
Can they prefer an
And
alternative
also
drug
abdominal pain
for-
also. That is common with clofazimine due to deposition of crystals.
So can they choose to have another drug in place of clofazimine? Can the patient choose to have, and if they insist, are we justified in giving another drug?
Usually, better to give clofazimine itself because it has got other beneficial effects also in leprosy, like anti-inflammatory action. But the
Young girls, not married,
that is
looking
a
out
problem.
for grooms.
Yes,
Yeah.
yes.
So this is about rifampicin, rash, hepatitis, flu, discoloration of urine, the clofazimine. So how do we follow up these patients? It's not enough if we just diagnose a patient and leave the patient off. Our main role is to prevent disability. So at the outset itself, once we, even if it is a single patch, we have to undertake a neurological examination, check for the whole sensations, and then we always look to prevention of grade 0 disability going into grade 1 and grade 1 going into grade 2. So how do we ensure compliance? Ashni ma'am, will you take up this question? And if they default, how do you manage?
See, basically, the treatment adherence has to be ensured as from the first visit itself. So we have to, even before starting the therapy, we have to adequately counsel the patient what our plan is, how long we are giving the drug, and how frequently are we meeting. All those plans you have to give the patient, and we will definitely have to have an active follow-up of the patient if the patient is not coming for back for follow-up. Previously, we had a very good system, a vertical system. Now it is not there. So there are a few issues nowadays. But still, we have to keep the patient under follow-up. And if they are not coming back, we have to somehow contact them and make sure they are under follow-up. And some issues are there. One, maybe there are migrants who may be coming, just starting treatment, and then they may go somewhere. Or there are patients for us who come from outside India, who are abroad, and here they come for come here for treatment, and then they go. So in all those such cases, we have to be a little flexible. We can't even give 2-3 months MDT together, provided we are sure about the patient complaints. And regarding defaulter, see, the post-bacillary regimen is for 6 months. 6 months means 6 blister calendar packs need to be completed. And this has to be completed within 9 months. So if the patient is not able to complete the 6 months course within 9 months, he's supposed to be a defaulter. In that case, we have to restart treatment as such. Actually, we have to ideally reclassify the patient or assess again, see whether he's again in PB still or he has gone to MB, and then restart the treatment. Regarding MB, the treatment duration is 12 months and it has to be completed within 18 months. If not, again, we have to restart. And once MB, it is always MB. Next time, again, he will be in MB. Only in PB, we have to reassess and decide whether we need a reclassification. So counseling is very, very important as far as treatment adherence is concerned. And we should also address a few concerns of the patient, like their difficulty to come, stigma related issues, the clofazimine pigmentation related issues. I would say even if the patient is reluctant to take clofazimine, you counsel adequately and tell them that clofazimine is such an important drug in the regimen. And we know nowadays the the post-bacillary also has been including clofazimine has been included in the post-bacillary also, because clofazimine is such an important drug, even having anti-inflammatory action, which is important in type 2 lepra reaction. So as a whole, and also we have a depot available for clofazimine in our body. So as a whole, clofazimine is a very important drug. So reluctance to take clofazimine only because of pigmentation need not be entertained. We have to actually adequately counsel the patient and encourage them to take clofazimine. So counseling is very, very important in patient for treatment complaints as well as for the prevention of deformity and disability.
Yeah, ma'am, thank you. That is a good point. And coming to disability prevention and medical rehabilitation, this is a self-care kit. So Viju sir, do you give your patients this kit yearly once or twice with an MCR shoe, chappals also? You've already told that. What is there in the self-care kit?
Yeah, in the self-care kit, it contains liquid paraffin is there. You have bandages, you have dressing, you have betadine lotions for dressing. These are the things that we give in the government hospitals. Basically, in the PHCs, they give such things. And you also prescribe them MCR chappals also as a part of DPMR. And to prevent the disabilities, we are also supposed to give steroids in patients who require type 1 or type 2 reactions. And also make available clofazimine also, because at sometimes the patient, even after stopping the MDT, we have to give clofazimine with the oral steroids. We also tell them how to, the dressing is done. Everything we just demonstrate to them.
Yes, sir. And the SSDO also. Soaking, scraping, dressing and oiling. That is a short abbreviation we use. Soak for half an hour and scrape away the calluses, and then do a dressing and then oiling, and then wear the MCR. But the cosmetic appeal of the MCRs are nasty and patients don't comply. So in this juncture, what do you do? Anybody can give an alternative, like how the MCRs, can they be modified? Any experience?
Yeah, what really it does is it doesn't aggravate the problem, and to some extent, it can also help in healing the lesions, the ulcers, and also prevent the development of ulcers. Also, in the patient who hasn't developed, suppose the patient is having an anesthetic foot, using MCR can prevent the development of ulcers.
Are there cosmetically appealing MCRs anywhere? Is it available? Usually patients, when they wear this sort of MCR, which is supplied by the government, forgive me, Manigandan sir, they usually don't wear it and come to the OP. They say, we wear it around my home premises. We can't wear this all along coming here because it itself causes a stigma. So anybody has got an experience of having very appealing MCR chappals provision or supply?
Yeah, it is available, but not in the government sector. But there are people, cobblers, who do it in a very good way. There are shops who do it. Diabetic clinics are providing it for the diabetic patients, and many of our patients go over there and get it from there. But it's very expensive also. It's very cosmetically, it doesn't look like our traditional MCR chappals.
Madam, can I add? Actually, nowadays the MCR chappals which are coming in program are better looking, aesthetically better. And one thing our PMR department does is they ask the patients to buy their own chappals or shoes, whatever they wish like, and they customize it for them by adding an MCR sole into it.
Yeah,
That I have seen.
that is what we also do. Okay, ma'am. So, Pradeep sir, can you throw some light upon how to differentiate trophic
Yes,
ulcers
yes.
of Hansen's
Actually,
and diabetes?
right. Actually, I would like to say trophic ulcers are wrong. We use the correct term is plantar or the neuropathic ulcer. Okay.
Yeah.
Now,
Okay.
in both in diabetes and case of Hansen disease, you can get neuropathic ulcer, plantar ulcers. How do the presentation of the plantar ulcer, this diabetes or Hansen disease, the one and the same. And how do you differentiate? Number one, you won't get nerve thickening in diabetes. A person with nerve thickening and plantar ulcer is more likely to be Hansen disease. Then, in diabetic, it is basically a sensory type of neuropathy. You won't get motor neuron. Whereas in leprosy, sensory motor neuron. So, person coming with a plantar ulcer and the sensory motor defects, nerve thickening is definitely leprosy. These are the simple points. But the trophic ulcer, the plantar ulcer per se, both is more or less the same, not much difference in the appearance or the presentation.
Yes, sir. And even the deep tendon
reflexes actually only in very late stages of leptoencephalic reflexes are actually diminished. Otherwise, in most cases, it is maintained. In diabetes also, sometimes the reflexes can be in early stage and late stage it can be actually diminished. Only in late cases of LL leprosy, the reflexes are actually diminished. Otherwise, it is more or less normal.
Yes, thank you, sir. So this is a foot drop. It's again for the doctors who have not seen a foot drop. So what are the red flag signs of foot drop, early warning signs? Ashni, ma'am.
Ma'am, whenever there is
actually these questions for our it was for Roy sir. Sir has left. Yeah.
Yeah, for the as far as the dermatologist is concerned, actually, I would like to say that we have to have a look about the patient as a whole. So the moment the patient walks in itself gives the first clue. So that high stepping gait and all, and we usually neglect such things is what I have felt. We examine the patient in front of us in the chair only. So you have to actually observe the way he comes in, and also if needed, if you are in doubt, you can ask him to have a move around so that we can actually analyze it. And then of course we can do all the tests related to the muscles and the voluntary muscle testing, as well as the individual muscle testing that we have mentioned. And that will surely show. And again, we can go for the other investigations like NCS to know the subtle neuritis and the high resolution ultrasound. In very rare cases, usually it is foot drop. The initial picture is clinically we can know. And peripheral nerve palpation also, the tenderness is a very important sign, which is indicative of neuritis.
So, what are the mimickers, ma'am? If there is no nerve thickening, are we in a fix?
Foot drop, I would say there are a lot of conditions which can cause foot drop, traumatic, other vasculitis, many other conditions. So again, we'll go back to the if there are no skin lesions, only foot drop, only nerve involvement, we'll have to go back to your cardinal signs of leprosy. If there is peripheral nerve thickening with sensory loss or or motor weakness of the associated muscles, we'll have to think in terms of leprosy. And if we are confused if it is thickened or not, anyway, it's a subjective thing, the peripheral nerve thickening. We can take the help of a high resolution ultrasound. There we can clearly compare the two sides, the cross-sectional area we can compare. And also there are cutoff points mentioned in various studies and articles. We can compare it with them and decide if it is really objectively thickened. And if it is objectively thickened, plus there is sensory loss or motor weakness, again, we are justified in treating it as a pure neuritic leprosy. And regarding neuritis, again, as sir already told, Roy sir told, the Doppler can have an important role. The vascularity, increase in vascularity is an early sign of neuritis. And again, there will be other features like architectural distortion and all other features which can add on to your diagnosis.
Pradeep sir, is nerve biopsy indicated in such cases? And what are the sites you would go for?
What can you repeat? What?
Is a nerve biopsy indicated in this case?
Nerve biopsy is definitely indicated when you make a diagnosis of pure neurotic cancer. Otherwise, there is no way we can confirm it. With nerve thickening alone, it's not possible because any conditions in neurology can cause nerve thickening. And keep in mind, we are giving treatment for 6 months to 1 year with potentially dangerous drugs. Nerve biopsy is definitely indicate the case of cancer is pure neurotic type, and we will have to take a nerve biopsy.
So what are the nerves which you would prefer to
Usually
take a
the nerves we take are the superficial cutaneous nerves. From above downwards, I'll mention the nerves. The commonest nerves we take are the sural nerve and the radial cutaneous branch of the radial nerve. But you can also use the supraorbital nerve, even the supraclavicular nerves also can use. Sural nerve is the commonest which we use in the medical course, and radial cutaneous branch of the radial.
Okay, sir. Thank you, sir. So this is lag of thalamus and Sarin sir.
There are a few questions in the chat box. Can you just see them?
No, Ashwin, I think it's already going to be
finished.
11 o'clock.
We have just reached the last slide.
I think we can fast take up the questions and wind up.
Yeah,
Yeah,
this is the
I think
last
we
slide.
should wind up now.
So here there's a case of lag of thalamus. Pradeep sir, how do we differentiate from Bell's palsy? There are a lot of cases who have been on treatment for Bell's palsy and actually
the lag
leprosy.
of tyrosine in cancer disease is lower motor neuron palsy and is usually unilateral, whereas in Bell's palsy it is bilateral and upper motor. That's the main difference. But we actually report recently a case of bilateral facial palsy. So that is the only simple way to distinguish it.
And these are the self-care measures. Usually we are taught to teach the patient to pull the lateral side of the eyes up, like how we say in Down syndrome. They have to do it 20 times, 3 or 4 times a day for getting back their muscle power of the eyelid, and they have to shield their eyes, and especially while they go to sleep. And Suraffi is also indicated. So here we wind up. Anybody would like to put in any good points and wind up with all the key messages? Sarin sir, would you like
Madam,
to add a few points and then we'll go to the chat box and finish off?
The problem with the lagostalmus can be exposure keratitis. So, corneal fields and lateral tarsonography can be done. Not possible, then at least cover the eyes. Also, it's a
Okay, sir.
temporary method.
Yeah, thank you, sir. Thank you so much, sir. Joan, ma'am, can we go for the questions in the chat box?
Joanne's cousin is sick, so I think she left the CME. So I think we'll go to the chat box and finish the questions. Cover the questions there.
Tarun, you're there?
ma'am, should I?
Yeah, Ashwini, if
Yeah,
you can
ma'am,
do it.
I'm there. I'm there. Yeah.
Yeah.
Yeah, Tarun, if you can read out those questions, or Ashwini, ma'am, if you can.
I think Dr. Ashwini can take it up.
Yeah,
Ashwini,
that's it.
please.
One question. Why in some cases SSS when done shows negative result, but on biopsy it shows positive?
Shall I
Can
take
I
that
answer?
question, Ashwin? Shall I take it?
Yes, sir. Yes, sir.
Okay,
Yes,
it's very
sir.
simple. See, every test like we just got a sensitivity and a specificity. When you're doing a slit skin smear or earlobe smear, there must be a meaning of 10 raised to 4 Besler per square millimeter. That is only seen in the BL and LL cases. So in BL and LL, definitely get a positive, whereas in BT is much less, we won't get. But in histopathology specimen, definitely we can get. That is a simple reason. Because of the sensitivity of the ELS and slit skin BR. And when with PCR, with 1 Besler, we can diagnose. Minimum 10 raised to 4 Besler per square millimeter of tissues required for a smear to be positive by our technique. So,
Next question. Are blood tests for leprosy patients free of cost in government medical colleges?
in government medical, in my medical college, definitely in Trivandrum and Alleppey, it is free. I'm sure in Kottayam also.
Kottayam also it's free.
Yeah,
It's free,
it
sir.
is.
When we
It is
have
free.
that seal, it is free. We have to
Yes,
write it
yes, it
actually
is.
somewhere.
Actually,
This
it is free
thalidomide,
for actually it is
yeah,
free for leprosy patients. There is a government order for that. They have to
Yes,
pay
there is a
nothing
government.
for any services, not only blood tests,
yeah,
USG, anything.
yeah. Next is thalidomide available freely.
In my government medical college, Alleppey, it is available free in the ward.
Yeah.
It is available.
Here also it is available, but not always in Kottayam.
Always. Otherwise, outside the pharmacy, it's not that easy to get.
It's costly also outside.
Costly also, right?
Then is Nikush portal accessible from medical college? Actually, that was my question only. So Dr. Setulakshmi DLO Pathanamthitta has answered it. It is accessible for DLO and block medical officers, and ID is given to the blocks. So I think from MCH it has to be entered by the DLO. Then Simi madam has commented type 1 lepra reaction can sometimes be misdiagnosed as erysipelas cellulitis. Very
Yes,
true.
true.
Simi madam's question is PCR available in India to diagnose indeterminate leprosy?
Not
Actually,
indeterminate. Definitely, DNA PCR is available
PCR
because
is available.
if you want to diagnose a drug resistance, we send to Chengalpet or Karigiri. There we send the specimen and they do DNA PCR.
PCR,
It is
yes.
definitely
And
available, but for indeterminate as such per se, I'm not very sure.
unlikely to
Yes,
yield.
it is available.
It is
Yes,
available free of cost for Kerala in Chengalpet.
Chengalpet.
Chengalpet is our what we
Shefflin
say
Institute,
nodal
Karigiri.
center. Shefflin is
Yes,
the for Karnataka. For
yes.
if you send to Shefflin, sir, it will be
You have to pay.
costing some some amount actually. Whereas in Chengalpet, it is free for Kerala because Kerala Chengalpet is a nodal center for Kerala. It can be done, but indeterminate may not yield result. Even in BT, only 50% can be positive. Next question, what are the changes on, I think it's nerve conduction study in leprosy?
Shall I take it, Ashwin?
Yeah, yes, sir, sure.
Only 3 changes simple. That is decrease in amplitude, decrease in velocity, increase in latency. 3. 2 decrease, 1 increase. Finish.
Okay, so that completes the question. Rest of us just compliment that it's a good session. So no more queries. So over to Madam, Deepa Madam.
Pradeep sir, can you just wrap up the key messages which we would like to put across for an early diagnosis and for the prevention of disability?
Most important thing is that because we are now in the so-called elimination phase by 2032, bring the incidence to zero, which I am sure this won't be possible. For the GP point of view, the cardinal signs should be kept in mind. That is, do not miss a case of Hansen's disease, especially asymptomatic hypopigmented patches. And once you encounter a case of Hansen disease, if you cannot do, you don't have the facilities we need to confirm the diagnosis, you refer to the nearest center. Then number 3, on starting therapy, you have to keep in mind that this drugs have got some toxicity, and more important, the patient can develop lepra reaction, which may be very distressing to the patient. You will have to counsel the patient regarding lepra reactions and ask them to visit the physician at the earliest. Then the last, the drug reactions, the adverse effects of this drug should be taken into account. And then already some patients will come with deformity. When you encounter patient deformity, means late diagnosis. That has to be managed by the physical medicine department, the surgeons, etc. So these are the things for the GP point of view. Keep an open mind when the patient comes with an asymptomatic patch. Erosions, blisters on the hands and feet cannot be explained, or a chronic non-healing plantar ulcer which cannot be explained. Okay.
David sir, would you like to add some key message as an IADVL president, as our president of IADVL?
The whole idea of this session was to bridge the gap between private practitioners and the government sector doctors. So I think this session has wonderfully done that. Bridging has been done wonderfully. I would like to thank all the panelists and the moderator, excellent moderator, for this wonderful session. Thank you.
Yes, sir. Manikandan sir, anything more to add, sir, to our program? Any programmatic directions from your side to us?
Really, in CMA, actually, even general practitioner ഉൾപ്പെടെയുള്ളവർക്ക് ഇൻഫോർമേറ്റീവ് ആയിരുന്നു. ശരിക്കും നമ്മുടെ ഒരു എനിക്ക് 2-3 കോളുകൾ എൻ്റെ ഫ്രണ്ട്സ് വിളിച്ചിരുന്നു. ശരിക്കും നല്ല ഇൻഫോർമേറ്റീവ് ആയിരുന്നു എന്നുള്ളത്. വെരി ഗുഡ്, താങ്ക് യു. ഒന്നേ ഉള്ളൂ, 2030 ഓടുകൂടിയൊക്കെ അറ്റ്ലീസ്റ്റ് കേരളത്തിൽ നിന്നെങ്കിലും നമുക്കത് ലെപ്രസി ഇറാഡിക്കേഷൻ ഉണ്ടാകണം. അതിനായിട്ട് നമുക്ക് എല്ലാവർക്കും ഒരുമിച്ച് കൈകോർത്ത് വർക്ക് ചെയ്യാം. ഓൾ ദി ബെസ്റ്റ്. താങ്ക് യു.
Thank you, sir.
So I think we'll wind up, sir. I would invite Dr. Renuka to deliver the word of thanks.
Good evening, everyone. As we conclude this highly interactive and informative case-based panel discussion about Hansen's disease from the experts, it's my pleasant duty to express vote of thanks. First, I would like to express our deepest gratitude to our eminent panelists for sharing their practical insights into the early diagnosis, discussing clinical cases, deformities, reaction management of leprosy. We are thankful for the in-depth discussion on breaking the stigma of leprosy, addressing the challenges in MDT, the commitment to a leprosy-free India. I thank Dr. Manikandan, J, Deputy Director, Public Health and State Leprosy Officer, Kerala Health Services Department, for joining hands with IADVL in the fight against leprosy. Thank you, sir. I thank Dr. Roy R. Chandran, IMA, Kerala State Secretary and Professor of Physical Medicine, Government Medical College, Kozhikode, for spending his valuable time and doing felicitation in the occasion, and also for sharing his knowledge. Thank you, sir. I thank Dr. S. Pradeep Nair, Professor and HOD, Department of Dermatology, TD Medical College, Alappuzha, for sharing his expert knowledge with us. I thank Dr. Sribiju MK, Consultant Dermatologist, Government Hospital of Dermatology, Chevayur, for sharing his vast knowledge and expertise. I thank Dr. Sarin A, Associate Professor of Dermatology, Government Medical College, Thrissur, for being part of the discussion. I thank Dr. Ashwini R, Assistant Professor, Department of Dermatology, Government Medical College, Government Medical College, Kottayam, for their active involvement in the discussion. I thank Dr. Deepa Bailopilli, Consultant Dermatologist, Government General Hospital, Ernakulam, who did moderate the panel discussion in the most lively and active way of hair on style. And I thank Dr. David Pudukadan, President IADVL Kerala. I thank Honorary Secretary IADVL Kerala, Dr. Joan Felicita Sampson. I thank Dr. Bobby Krishna, Treasurer IADVL Kerala. I thank Dr. Radhamani M, Chair IADVL Kerala, Community Dermatology and Media Cell. I thank all the members of the committee for planning this program. I thank all the participants of the session. And in conclusion, let us carry forward the lessons from this session to improve patient care and reduce the burden of the disease. Thank you all. Thank you. Good night.
Thank you, Tarun, and thank you. Special thanks to Celia ma'am, who did all the job behind the scene for the flyer, and she's done a lot.
Thank you all. Thank you all. Good night.